Okay, good afternoon, and welcome to the Health and Human Services Committee interim hearing. My name is Senator Ben Hansen, and I represent the 16th Legislative District in Washington, Burt, Cumming, and parts of Stanton County, and I serve as chair of the Health and Human Services Committee. I would like to invite the members of the committee to introduce themselves, starting on my right with Senator Ballard.
Bo Ballard, District 21, Northwest Lincoln, and Northern Lancaster County.
Murph Rigby, Legislative District 12, which is Omaha and Ralston.
And Senator Kavanaugh was going to try to call in here, so she's going to try to join us here shortly. And Senator Walls just indicated that she's going to be just a little bit late for today's hearing, so she'll be in here shortly too. So also assisting the committee is our research analyst, Bryson Bartels, and our committee clerk, Christina Campbell. A few notes about our policy and procedures for today. First, please turn off or silence your cell phones. This afternoon, we'll be hearing 5 interim study resolutions. We'll be taking them in the order listed on the agenda outside the room at the request of Senator Blood. LR233, LR232, and LR132 will be combined into one hearing. The hearing on each resolution will begin with the introducer's opening statement. At the request of the introducers, all 5 resolutions heard today are limited to invited testifiers only. After the opening statement, we will hear from those individuals. I'll call them up in order. The introducer of the resolution will then be given the opportunity to make closing statements if they wish to do so. For those of you who have been invited to testify, you will find green testifier sheets on the table near the entrance of the hearing room. Please fill one of them out and hand it to Christina when you come to testify. This will help keep an accurate record of the hearing. I'm asking that you try to limit your testimony to 5 minutes each. The light system, which you'll see in front of you when you come testify, will give you an indication of how long you've been speaking. At 4 minutes, the yellow light will come on, and at 5 minutes, the red light will come on, which we then ask you to wrap up your final thoughts. These are study resolutions for information gathering purposes only and not bills, so there's no record of proponents or opponents. However, if you wish to submit written comments for the record, you may do so online via the chamber viewer page for each resolution. Online comments must be submitted prior to noon on the work day before the hearing in order to be included in the official record. And obviously, it's a little bit too late for today's resolutions, but I just want to point that out, that the feature is still available on the legislature's webpage. So with that, we will welcome Senator Blood to introduce the 3 LRs for today.
Thank you, Chairman Hansen, and good afternoon to you and the members of the Health and Human Services Committee. My name is Senator Carol Blood, and that is spelled C-A-R-O-L, B as in boy, L-O-O-D as in dog, and I represent District 3, which is the western half of Bellevue and eastern Papillion, Nebraska. I appreciate the opportunity to bring forward LR132, LR232, and LR233, all interim studies exploring Nebraska joining 3 new interstate compacts. LR233 relates to the Interstate Compact for Physician Associates. LR132 is the Interstate Compact for Dentists and Dental Hygienists. And LR232 is the Interstate Compact for Social Workers. The Department of Defense has partnered with the Council of State Government to fund and support the development of 2 of these 3 interstate compacts for occupational licensure. And this has been a driving force for this effort. It is my hope that by bringing everyone together during the interim, we can be better prepared when it is time to bring forward the legislation in January. And this committee will be better informed on these topics. Occupational licensing interstate compacts allow professionals in licensed occupations to transcend state boundaries by creating uniform standards of practice. Interstate compacts are a legal contract between 2 or more states that allow the states to cooperatively address shared problems, such as workforce shortages. It allows the states to maintain sovereignty over issues belonging to states and to respond to national priorities with one voice. These compacts support professionals in state licensed occupations, including our military spouses. The goals of these compacts are as follows: to streamline licensing between states of the compact for all practitioners in that particular occupation, to support spouses of relocating active duty military personnel through provisions recognizing unique requirements of military life, to create streamlined pathways for interstate practice, to increase public access to care or services, to enhance the state's ability to protect the public's health and safety while preserving state authority over professional licensing, to encourage the cooperation of compact member states in regulating multi-state practice, to help maximize state membership in licensed professions, and it clearly enhances the exchange of licensure, investigative, and disciplinary information by means of a compact commission database. Now, it's no secret that every state in the United States has a workforce shortage, and Nebraska is not the exception. Nebraska's healthcare industry is one that suffers the most from this shortage. This shortage means limited access to treatment, especially in our more rural areas and other underserved communities. These shortages aren't just from states being unprepared when all were warned about the baby boomers aging out of the workforce decades ago, but also the result of certain federal and state policies and payments and provider capacity, to name only a few of the issues that have created this shortage. The burdens created within our healthcare industry also affects the mental and physical well-being of these professionals, creating the secondary issue of higher suicide rates, an increase in mental health issues, burnout, early retirement, and exhaustion, to name only a few of the concerns. As many of you are aware, one bright spot that emerged from many of these compacts was the emergence of telemedicine. Now, Nebraska has been a leader over the last 7 years when it comes to interstate compacts, and it is beneficial to our state if we can continue this streak of unified bipartisan success. So let's discuss each industry a bit before the testifiers step up and refine the facts for their particular industry for all of us. So the Council of State Governments, CSG, partnered with the Department of Defense, the DoD, the American Dental Association, ADA, and the American Dental Hygienists Association, ADHA, to support the mobility of licensed dentists and dental hygienists through the development of a new interstate compact. This compact will create reciprocity among participant states and reduce the barriers to license portability. Accessibility to dental care in the more rural areas of Nebraska is part of Nebraska's healthcare crisis. In the dental office, the dentist and the hygienist work together to meet the oral needs of patients. But there are certainly limits as to the clients they can provide services to if they do not have the staff to accommodate those needs. 43 counties in Nebraska do not have a single dentist able to help low-income Nebraskans. Patients, mostly those relying on Medicaid, in Western Nebraska are forced to journey to Lincoln to receive appropriate dental care. Studying the benefits of the dentist and dental hygienist compact will lead us to one of the avenues to mitigate Nebraska's workforce challenges in dentistry. We currently have 1,237 licensed dentists in Nebraska and 1,280 employed dental hygienists in our state. To put this in perspective, we have a population of 1.96 million. This compact can help to make these issues better. CSG partnered with the DoD and the Association of Social Work Boards, ASWB, with support from the National Association of Social Workers, NASW, and the Clinical Social Work Association, CSWA, lots of acronyms, to support the mobility of licensed social workers through the development of a new interstate compact. This additional licensing pathway will facilitate multi-state practice among member states and reduce the barriers to license portability. Social workers are people who are dedicated to helping others. They help vulnerable groups of people to overcome challenges and to meet their personal goals while providing important services to their community. There are many specialties with social work, along with specific certifications. A certified social worker is trained to help people while being compassionate and understanding of their needs. Social workers are advocates for people in their community and help them to solve problems. They help both individuals and families work through challenging situations like poverty, addiction, and unemployment. They help raise awareness both for and with the people that they represent on a local, state, and national level. Social workers require knowledge in many areas, including human development, behavior, social, economic, and cultural institutions, and an understanding of how all these things work together so they can help those whom they serve. Now, as this committee is well aware, there is a shortage of behavioral health workers throughout Nebraska. To receive appropriate care from licensed social workers, Nebraskans often must travel to more metropolitan areas to receive necessary care, if they are lucky enough to procure an appointment. This is especially concerning for our at-risk children, adolescents, and transition-aged youth with behavioral problems. This new compact is part of the solution as to how we start to address this shortage. In June of 2019, a joint initiative by the Council of State Governments, the Federation of State Medical Boards, the American Academy of Physician Associates, and the National Commission on Certification of Physician Assistants was created to develop an interstate compact for the interstate practice of physician's assistants. Funding supported for this initiative actually came from the Department of Health and Human Services. The Physician Associates Licensure Compact will facilitate the ability of licensed PAs to practice in multiple states without having to obtain an individual state professional license in each state of practice. The compact will provide for greater in-person and telehealth access to care and will significantly enhance practitioner mobility, including in times of public health emergencies. The PA compact will also strengthen public protection by establishing a data system that facilitates information sharing and coordination on disciplinary action between participating states, as do all the compacts. In the PA compact licensure mobility, it is facilitated through a privilege to practice model, which allows individual licensees to seek a compact privilege in any compact member state they choose. The licensee's application for a privilege to practice in a specific state is expedited by utilizing the compact data system to ensure the individual is eligible for that privilege by meeting the requirements in the compacts. PAs are versatile and collaborative. They practice in every state, in every medical setting and specialty, improving healthcare access and quality. They provide flexibility amongst health professions because of the versatility and adaptability, and they are also trusted, well-educated healthcare providers. Now, I became involved with interstate compacts because of their benefit to our military spouses and their families. Military spouses tend to be underemployed and unemployed for a variety of reasons. When you consider the national unemployment rate is 3.5% and the unemployment rate for military spouses is 20 to 25%, it's clear they suffer a rate that is 5 to 6 times greater than the national average. But why is that? Especially when there's clearly a workforce shortage and jobs available. Well, you should know that 60% of military spouses report that they are looking for full-time or part-time employment because they do need 2 incomes for financial stability. But they have hurdles that are common with other members of the workforce and others that speak directly to being in a military family. Military spouses also experience substantial income loss after a military transfer for a variety of reasons, such as job availability at a new location, licensing requirements for their occupation, and the cost of living in a new state. But for today's purpose, we're clearly focusing on the licensure issue. According to a study by the U.S. Chamber of Commerce Foundation, military spouses earn an average of $12,374 less per year than their civilian counterparts. Some of the reasons for the income loss are frequent moves, licensing barriers, childcare costs, and a long list of other reasons. There have been alternatives proposed to interstate compacts, including universal licensure. Now, I want to discuss why the interstate compacts are the best options for Nebraska and what the other proposals lack in proper regulatory structure and oversight of industries. So in recent years, states have worked to reduce barriers to interstate mobility for licensed professionals through these interstate licensure compacts, or statutorily enacted agreements among states allowing licensees to practice across state lines, and universal license recognition laws in which a single state determines its unique process to grant a license by endorsement to a license holder from another state or territory. Now, these policies help to solve similar problems, but there are several major differences. Notably, compacts are tailored to a particular profession, and they allow licensees to engage in interstate practice in all compact member states, whereas universal recognition laws attempt to account for most or all professions a state regulates, but only with regard to practice within that state's borders. Universal recognition sounds like a great idea, but is proving to be problematic in other areas, especially for our military families. Universal license recognition, the laws do not provide for true reciprocity, instantaneous recognition of another state's license, and may still require an application process and allow for some discretion by the licensing board in license decisions, even though they have the intended effect of lowering the threshold for license portability in a state and reducing time to licensure. These types of policy do attempt to streamline licensure on a wider scale, often lowering the thresholds for licensure across a variety of professions and reducing time to licensure. But to mitigate conflicts of difference of standards across states, ULR grants licenses for substantially equivalent or substantially similar experience. That's how they're usually written. While on the surface this appears easier to implement and casts a wider net to fill in job vacancies, universal licensure weakens licensing requirements. Diluting requirements and licensure can end up harming employers and consumers, especially in the industries we're discussing today. A recent study done by the Alliance for Responsible Professional Licensing found that 85% of businesses would have less confidence if licensing in their industries were downgraded. If we become too hasty in addressing workforce challenges through programs like universal licensing, we eliminate or weaken crucial safeguards in high-impact industries such as healthcare. What could result is a decline of quality and increased liability for those businesses. A good example of this in Nebraska would be our massage therapy industry. Our state requires hundreds of hours more in training than many other states, and the industry is adamant that they want to keep the bar high because their consumers demand it to be so. And so it's likely that a massage therapy compact, based on the conversations we've had this year, will never pass in Nebraska because of those issues. Feedback returned on ULR policies found some applicants felt applying for out-of-state licenses became more confusing and difficult to manage for boards. States with a residency requirement were made more difficult with the ULR licensing process, while interstate compacts addressed that very hurdle. ULR attempting to address licensure differences across states has also seen some negative results. The substantially similar criteria has run into problems as definitions of occupations differ from state to state. That language doesn't always solve disagreements between states, boards, and licensing bodies, as sometimes applicants from out of state receive licenses despite having significantly lower requirements than in-state licensed practitioners. Also, with increased traffic of out-of-state applicants, some state boards systems were overwhelmed and not outfitted to handle an increased influx of applicants. Interstate compacts address these problems as states within the compact collaborate to resolve differences in license and share databases of applicants. Interstate compacts would protect employers and consumers in Nebraska while addressing workforce issues in a responsible manner without diluting the qualification process. Licensure compacts and universal recognition statutes can coexist without conflict or redundancy as long as provisions to exclude interstate compacts are inserted into the universal recognition bills. Enhancing the ability of practitioners to engage in interstate practice requires more than a one-size-fits-all approach. States should account for industry-tailored reciprocity mechanisms, such as interstate compacts, when crafting these new universal recognition laws, and understand that neither reciprocity nor ULRs are the end-all solution for this problem. With that, I'll step aside and have the testifiers come forward to talk more about the benefits of these compacts that they have to their particular industries, and also hopefully paint a more comprehensive picture of why we need to continue on this path here in Nebraska. Sorry for the long introduction, but there were three of them.
Oh, you got all three of them in there, so that's good.
I did. I talked as fast as I could.
All right, thank you, Senator Blood. Are there any questions from the committee? Just make sure. Yes, Senator Reapy.
Thank you, John. Thank you for being here, Senator Blood. To your credit, you have been the champion for these particular movements, if you will, if I may call them that, on the compacts. And you've done, as usual, a very thorough job. You've always been known to do your homework. I've worked with you on committees. I'm proud to say that. I also would note that because of these handouts, I think it's fair to assume that you have the support, if you will, from these different groups.
Absolutely,
Now,
especially.
the other selfish question that I would ask from the state of Nebraska is, on the net effect of compacts, will that increase our worker supply or decrease it? Will there be more moving away from Nebraska than moving to Nebraska?
That's a fair question. I've been asked that on other compacts. And I can tell you that data does not show that people move out, they move in. For our military spouses especially, right? We want to make sure that they can hit the ground running because we have this highly educated workforce that ends up having to jump through hurdles to get things done and are losing out on income and are not able to get to work as fast as we possibly can get them to work. So I can only go with the data. You know me, I always say data, facts, and science, right? And the data for the other states that participate in compacts, nobody is experiencing that. What we are seeing are people that live in more rural areas that live close to borders, that can't find jobs locally, do have the ability to cross that state line into a neighboring compact state such as Kansas, Iowa, Colorado, and have the ability to generate a better income as a result of the compacts. So that's the only thing that I've been able to document are people that are living on borders. They're not moving, they're staying in their little towns, in their little communities or their farms, but they are having to cross that border to work because it's a closer drive. So, and I think that's positive because they stay in Nebraska and spend their dollars here and raise their families here. So, but that is a common question, but data shows that that is not a fact.
Well, we do live in a free society and where they are not indentured servants. So
It's true.
our job is to try to make it appealing enough that they prefer to be in our communities and to not leave our communities for any and all reasons. But
And it's our job to pass the laws that make it as easy as we can to remove these hurdles. And this is just one of the tools we can put into our toolbox, as we've done, I think, 7 times in the last 7 years.
I know there are some other professional groups that are looking forward in the future for compacts. And so
There are.
maybe you'll have to take a break and come back and run again. And then for
Gee, that
another-
sounds like so much fun. I'll have to consider
for
that.
another 8 years, and away you go. Okay, thank you, Mr. Chairman. Appreciate it.
Any other questions from the committee? Senator Ballard.
Thank you, Mr. Chairman. Thank you, Senator Blood, for being here and for your advocacy of this issue. How long has this been an initiative of theirs?
So to my knowledge, at least 7 years, because to be really frank, one of the very first meetings I ever went to as a freshman senator, I ended up, it was very happenstance, sitting next to a CSG somebody who was working with CSG who was from the DOD, and we were part of his territory. And he asked if I had heard of interstate compacts, which I had not. And he had said that he had brought them forward to the previous senator from my district, who was uninterested in taking, we could have been further ahead than we are already, in taking these on, and would I like to learn more about them. So I know, so that would be at least 8 years, I guess.
8 years.
And we have people from CSG that can maybe answer that better than I, but I know that every new compact that has been created, we have usually picked them up within 30 days if we're in session. So we are far ahead, but I know at least 7 to 8 years. And I can get you information on the contract, but they have paid CSG, and CSG has put together a roundtable of experts. So they bring people in from the profession, they bring in legal minds, because of course we want to make sure that legally these are correct. They bring in policymakers from all over the country. I was just in DC last week talking about the dental compact. So they've got it down to a science. It's like a little compact factory. But the reason they got involved with this is because they wanted to find something that could be unified throughout the United States that was consistent. So these military spouses didn't have this constant hurdle of trying to figure out which state does what and what hurdles they'd have to walk through. And they were finding things like reciprocity and universal licensure was not helping their military spouses for the reasons that I mentioned. And they saw this as a solution, and it's been a very good solution. I have had several other things happen that were similar to the compacts that we didn't have to push through as policy, that we were able to just do, like for the military spouse attorneys, through working with our departments here in Nebraska. But we find that it's much easier to do the compacts because then we know it's in writing and that it's similar in all states that join the compact. We were going to originally bring, and in fact, I think he was actually the liaison for that. We were originally going to bring it forward as a compact, and they're like, hey, we think we can do this without a compact, and we did. But that's not true of the medical professions.
And you're not, you answered with Senator Reepe's question, does DOD track metrics on this?
Oh, they do. Yeah.
Okay.
Yeah, absolutely. I think Michelle, who would have been here and couldn't, from the DOD, who represents this specific area, wrote a letter of support in the system. She's somebody that you can definitely meet with, or I can have other people contact your office and share those metrics with you.
Okay.
But they would not have invested further money had it not worked from the very beginning.
Okay, thank you.
Any other questions from the committee? All right, seeing none, are you planning to stay to close?
I am.
All right, good deal.
Thank you.
So with that, we will take our first invited testimony. And on the list that I got here, I have Susan Ray with UNO. Would like to testify first? She put you up first, so you must be like, the best there is.
Pressure's on now.
Yeah.
Hello, hi, my name is Dr. Susan Ray, spelled S-U-S-A-N, last name R-E-A-Y. My doctorate's in education. I'm a licensed clinical social worker. I am the director at the Grace Abbott School of Social Work at the University of Nebraska at Omaha. However, I'm not here representing the University of Nebraska's position. I'm representing myself as a social worker. I was on the board of mental health practice in Nebraska for about 13 years and term limit off in 2021. My area of research is regulatory science, and I do a significant amount of research in the area of licensing, particularly with social work. I am also a practitioner of social work. I have some prepared testimony that I provided, but I believe that, and I could say a whole lot about how this is a really great thing, but I think it's best articulated by telling you a short, very brief example of why this is important. In my practice, about 2 years ago, I had a college student was seeing me. I was her social worker. She had a very significant eating disorder. She was in college in Nebraska, but lived in another state. She decided to take the semester off from school and go home to be with her family and to be taken care of. I was not licensed in the other state, and I felt that it was important that her care continue, particularly during this very significant time in her life. However, I went through the process of trying to get licensed in this other state and made many, many phone calls. I went through lots of hoops, found out I needed to do fingerprinting, background checks. I needed to have my college transcripts from my master's degree, which was in 1998, officially sent from the university, and that I would need to fill out a whole lot of paperwork and pay some fees. That took me probably 5-6 hours total to figure even out what I needed to do. And then the process of doing all of that, submitting it, and then waiting for the other state's turnaround time to be about, they said 6 to 8 weeks for that paperwork to be processed. I figured it's not going to happen. This student is going home this week. And by the time all this gets done, she will be back already. I turned my focus to finding her a social worker in the state where she lived, went through the process of figuring that out, talked to the other social work, did all of that. And in the end, the student and her family decided by the time all the insurance reimbursement got worked out, they got on the other person's waiting list, it would also be about the same amount of time for her to seek treatment there. She would already be back at school in Nebraska. So she did not get treatment while she was home with her family for that semester, which caused significant stress for her and her family. They were up in the middle of the night checking every hour to make sure that she wasn't exercising. The daughter did not get any mental health care. I was not able to provide care to her. To Senator Blood's point about the stress of the practitioner, the social worker in these situations, there's really not any amount of self-care that you can do as a social worker to prevent yourself from not worrying about people. And in this particular situation, it was something that did keep me up at night. She ended up coming back to school in Nebraska the following semester, and she was rested and she felt loved, but the pathology of her disorder was so significant, it was worse than when she was there before. And so it basically set her back a very long time in her treatment and undue suffering for everyone involved. I believe that this process and this study, interim study, is so critical to what we do. We need to figure out a better way to do this. And I very, very much appreciate your time on this, and to Senator Blood and everyone else's attention here, because this sort of legislation helps us to feel seen in our practice and helps us to feel valued in what we do. So thank you very much.
Thank you for your testimony. Real quick, we'll just make sure to see if there's any questions from the committee. Are there any questions from the committee? Yes, Senator Repeat.
Thank you, Chairman. I have a short question. You noted that she had set her back. Did she have irreversible damage?
She ended up, it's hard to say, she's doing really well. I don't know if the process would have been shorter for her or the pathology would not have been as long standing, but it's a good question. I still have contact with her. She's doing really, really well and gave me permission to share her story with you all today. However, I believe it would have not taken as long for her to recover as it would have if her treatment would have continued.
Okay, thank you very much. Thank you, Mr. Chairman.
Thank you for coming to testify. Appreciate it. All right, we will take our next invited testimony, and I have in here Mary Bainey with the National Association of Social Workers. Welcome.
Okay, I'm going to read mine. Senator Hansen and members of the Health and Human Services Committee, my name is Mary Bainey, and MaryBahney. I'm a licensed clinical social worker in Nebraska, and I'm a member of the Nebraska chapter of the National Association of Social Workers. We say NASWNE. Currently, I'm chair of our chapter's NASWNE's Advocacy Committee. Our association is the state's largest organization of professional social workers, and we are a chapter of the largest national organization of professional social workers. In Nebraska, social workers who are licensed as mental health providers or practitioners or independent mental health providers or practitioners can provide mental health therapy services. I'm here to express support of our association for LR 232, the proposed Interstate Social Work Compact. The National Association of Social Workers at our national level states that the compact eliminates barriers to practice and increases access to care, especially in areas that are underserved and geographically isolated, as we have in Nebraska. Currently, social workers must obtain a separate license in each state in which they wish to practice, as Susan just explained in her example. This can be overly burdensome in time and money, as she said, for professional social workers. The implementation of this interstate compact will improve access to telemental health, improve continuity of care when clients travel or relocate, and it will ensure the safety of the public by allowing only licensed social workers to take part in this effort. The Nebraska chapter of the National Association of Social Workers strongly supports the implementation of the Interstate Social Work Compact. And thank you for consideration of this matter.
Thank you for coming to testify. Are there any questions from the committee? You're off the hook.
Hey, that sounds good.
All right, thank you.
You didn't ask me.
I knew it all.
All right, we'll take our next invited testifier, and I have in here Sarah Marish from Nebraska Appleseed.
Hello,
Welcome.
Chairperson Hansen and members of the Health and Human Services Committee. My name is Sarah Marish, Sarah Maresh, and I'm the Healthcare Access Program Director at Nebraska Appleseed, testifying on LR 132 on behalf of Nebraska Appleseed. We're a nonprofit legal advocacy organization that fights for justice and opportunity for all Nebraskans, and one of our core priorities is ensuring that all Nebraskans have equitable access to quality, affordable health care. Even though oral health is a critical part of overall health, many Nebraskans don't get the care that they need, and this is particularly true for people enrolled in the Nebraska Medicaid program. Even though some dental coverage is included for adults, a majority of adults with Medicaid aren't utilizing any dental services. Among adults with Nebraska Medicaid coverage, only 42.6% in 2018 and 41.9% in 2019 had an annual dental visit. Increasing access to dental care in Nebraska's Medicaid program presents a wide variety of benefits, from improving individual health to addressing racial disparities and to even supporting the economy. Nebraska Appleseed's recent policy brief covering these issues and more is available at the link in the testimony, but also is being handed out to you as well in a packet. We regularly hear at Appleseed from community members that even when they have coverage through Medicaid, they struggle to find dental providers that accept Medicaid and accept new patients. A potential interstate compact for dental professionals could be one opportunity to increase the dental workforce in Nebraska, not only for individuals with Medicaid, but for Nebraskans regardless of coverage. This new interstate compact that would support the mobility of licensed dentists and hygienists across the state is promoted by many organizations, many of which has already been shared. And states that join the compact would have reciprocity for dental professionals to move more easily from one state to another, supporting our workforce initiatives and also making sure that other folks in our state are able to access the dental care they need. Other healthcare professionals already have similar interstate compacts, including physicians, nurses, physical therapists, among others. This compact may be one way to address the dental workforce to better serve Nebraskans regardless of the healthcare coverage. And Nebraska Appleseed supports efforts to improve dental workforce and access to dental services. I'm happy to answer any questions.
All right, thank you for coming to testify. Are there any questions in committee? Yes, Senator
As
Beebe.
usual, I have a question, Mr. Chairman. Thank you. Thank you for being here. The one question I'm looking at your letter, and we're talking about the compact in this particular 132. And yet this handout talks about improving or expanding Nebraska Medicaid. I mean, is one dependent upon the other one, or is this just a copy that you had? You want to share this one as well?
Yeah, that's a good question. So the issue brief that we handed out actually deals with a variety of suggestions to improve oral health care in our Nebraska Medicaid program. And one of the suggestions, because of the workforce shortage issues, is to take up initiatives such as compacts to increase the number of dental providers that we have who accept Medicaid. So we at Appleseed have an interest in oral health care in general. And so this suggestion to include the interstate compact and have that adopted in Nebraska is just one of the suggestions in our policy brief as well, among with others.
My interpretation is correct me if I'm wrong, is that if you increase the number through the compact, you help everyone.
Yep, exactly, regardless of coverage. Yep.
Okay, I'm good. Thank you, Mr. Chairman.
Any other questions, Senator Day?
Thank you, Chairman Hansen, and thank you for being here today. So kind of piggybacking off of Senator Reepe's question, we know obviously on this committee that healthcare access, particularly in rural areas, is not great in Nebraska. Do we have any idea what that looks like, especially related to Medicaid dental access in rural areas?
Yeah, there might be. I don't have the exact information in front of me, Senator Day, but there definitely are shortages and challenges, and there may be people, providers in the dental space behind me that can better speak to some of the deficiencies in that. But we do know and hear stories of people having to travel long distances. And we've also heard stories of folks, trying to get higher level of care and not being able to access that and having to drive from, further out west to Lincoln or Omaha to get kids care, even for their children.
Excellent, thank you.
Okay. Seeing no other questions, thank you for coming.
Thank you.
And I messed up. I skipped over one person who was in line for the testifier. So with that, we'll take the next testifier, Joey Enright with the dental hygienist.
Yes.
Sorry about that. Welcome.
Thank you. So my name is Joey Enright. It's JoeyEnright. I am a hygienist in Nebraska, and I'm testifying today on behalf of Nebraska Dental Hygienists Association. First, I would like to just express sincere gratitude for the committee, for Senator Blood, for your attention and consideration to the Dental and Dental Hygienist Compact. As Senator Blood had said, this compact is an initiative of the Department of Defense, the Council of State Governments, the American Dental Association, as well as the American Dental Hygienists Association. So Nebraska Dental Hygiene Association believes that dentists and dental hygienists compact will improve access to care for Nebraskans at a time when workforce shortages are definitely creating some gaps. According to the Health Policy Institute's research, over the last few years, there is a mobility trend among practicing dentists with less than 10 years of experience. Between 2019 and 2022, 14% of this demographic moved to another state. As it stands, our state does not accept clinical exam scores from the testing agency that offers the most portability, which may increase the odds that licensure candidates will not stay in the area upon graduation from dental school. Entering into the compact is an opportunity for Nebraska to offer the portability that these upcoming professionals seek while increasing odds that they remain in the state to practice dentistry. According to the Department of Defense, military families move every 3 years on average, and 36% of military spouses require a professional occupational license for employment. The compact helps military spouses relocate and begin work without delay by reducing the amount of time and effort needed to gain authorization to practice in a new state, even as compared to expedited licensure laws for military spouses. As a member of the compact, Nebraska, the home of Offutt Air Force Base, may become a more attractive option to call home for a military family with a dentist or dental hygienist. The Dentist and Dental Hygienist Compact would utilize a compact privilege model of interstate practice, much like the 8 professional licensure compacts our state currently participates in. To utilize the compact, a dentist or dental hygienist must have a license in good standing in a state that is a member of the compact. This preserves the regulatory authority of each compact participating state and allows a participating state to continue to determine the requirements for licensure in that state. This maintains the state's unique scope of practice for all members of a profession practicing in that state, whether through a state-issued license or a compact privilege. Costs for participating in the compact are projected to be nominal by the Council of State Governments, but would incur due to additional software required to connect the compact's interstate licensure data system, as well as costs associated with attendance of our state's chosen commissioner to the annual Dentist and Dental Hygienist Compact Commission meeting, once the compact is enacted in 7 states. Thank you for your time and consideration, and I'm willing to answer any questions.
Okay, thank you. Are there any questions from the committee? Senator Miller.
Thank you, Mr. Chairman. Thank you for being here. I appreciate it. You mentioned 14% of dental hygienists are moving out of state. On the flip side, do you see a downtick in individuals going into dental education for dental hygienists?
Demand is still high. So programs, I've been tracking this, really since the pandemic, but I've been trying to pay close attention to those trends. It seems that there is still a lot of interest to go into dental hygiene and dentistry. So I'm not really fully sure of what is creating that kind of hyper mobility trend that we're seeing in professionals. But I know for myself, I am getting a lot of people reaching out just to move back to Nebraska from other states. So hygienists, I do some hiring for my business, and so they are interested in coming to Nebraska. So it's just a matter of, they have to figure out all the things that they have to do. What boards did they take? That's going to be a big obstacle for some people. Nobody wants to have to retake boards. It's just, it's costly. It's just a lot of work. So that's an obstacle that we have in our state. And so I think this could be a good solution to some of those issues.
But you aren't seeing a downtick in high school students.
They're
wanting to go
interested.
dental.
They
Okay.
want to go. It's there's some issues with just class sizes and accreditation and kind of the ratio of professors to students, and the programs are small, so the output of the professionals is not as great as it could be, in my opinion. But yeah,
Thank you.
that's a whole nother issue.
Thank you.
Anything else?
I might have a couple questions.
Okay.
So does this, just to make sure I get this right, I think I have an understanding of it. So somebody who has a good standing in licensure in another state, who may have less hours for licensure or continuing education hours, can now practice in the state of Nebraska?
So to my understanding, the licensee, they would have to know the rules and regulations of our state and follow them and practice according to that. So they would need to abide by those continuing education regulations that we have.
Okay.
So, and that's really no different than how you practice anywhere. I mean, as a licensee, you're responsible to know your scope of practice of what you can and cannot do, as a licensed professional.
Okay, just curious.
Yeah.
Seeing no other questions, thank you very much.
Okay, thank you.
Appreciate it. All right, next on the list is Isabel. Okay, I gotta pronounce this right, make sure I get it right. Eliason? Okay, right, I just butchered it, didn't I?
No worries.
Okay, from the Council of State Governments.
Okay,
Welcome.
thank you. Chair Hansen, I'm here today to talk about both the PA Compact and the Dentistry and Dental Hygiene Compact. So I'm gonna go through both of these at this time. All right. Chair Hansen, members of the committee, my name is Isabel Eliason, Isabel Eliassen, and I'm with the Council of State Governments. I would like to express my appreciation for your interest in the Dentist and Dental Hygienist Compact. My testimony is meant to provide background educational information on the compact. There are approximately 425,000 licensed dentists and dental hygienists in the United States. Despite the high demand for oral health services, licensees are currently limited to providing services within state borders. The Dentist and Dental Hygienist Compact seeks to provide licensees with opportunities for multi-state practice, support relocating practitioners, and foster workforce development by reducing unnecessary licensure burdens. The Dentist and Dental Hygienist Compact is an interstate occupational licensure compact. The compact was created through a cooperative agreement between the Department of Defense and the Council of State Governments. For the past 18 months, CSG has been developing the compact language with stakeholders in these professions, including the American Dental Association, American Dental Hygiene Association, state regulatory boards, the education community, and others. The compact will enable dentists and dental hygienists to get a compact privilege to practice in other states that join the compact, rather than needing an individual license in every state in which they wish to practice. The Dentist and Dental Hygienist Compact is similar in form and function to the 9 occupational licensing compacts Nebraska is already a member of. Practitioners must pass a background check and meet other eligibility requirements related to education and examination. The Dentist and Dental Hygienist Compact also benefits military families. If a military family gets assigned to a new duty station in a compact member state, the service member or their spouse can continue to work with the current compact privilege. If the family gets assigned to a new duty station that is not in a compact member state, the service member or their spouse do not lose access to the compact, but would need to get a single state license in their new state if they wish to continue working in that state. From a regulatory perspective, the compact preserves the authority of each member state to protect public health and safety. A licensee practicing in Nebraska under a compact privilege must abide by the laws and rules and regulations that govern the practice of dentistry and dental hygiene in Nebraska. Nebraska will be able to charge a fee for a compact privilege. Like all other occupational licensing compacts, the Dentist and Dental Hygienist Compact will be governed by a commission made up of compact member states. Nebraska's delegate will be a representative from the Nebraska Board of Dentistry. Overall, the Dentist and Dental Hygienist Compact will increase license portability for dental professionals in Nebraska, support military families, and improve access to oral health services for Nebraska residents. Additionally, by sharing investigative and disciplinary information among participating states, the Dentist and Dental Hygienist Compact will allow participating states to better protect the public. Increasing access to healthcare is a key issue facing states, and the compact can help alleviate that problem. I would be happy to take questions on the dentist compact, or I can just go ahead into the PA testimony as well.
Let's start with the dentist one first,
Okay,
just to make
great.
sure. Are there any questions about the dentist compact? Are there any states so far that have filed or enacted the compact yet?
Yes, there are. Unfortunately, I don't know off the top of my head which states. I want to say I think there are 2 or 3 that have already joined, a couple of others that have considered. We can definitely get you that information after this is over. We have it up on the compact website, but unfortunately, I just don't know off the top of my head which states that would be.
Okay.
Probably Utah is one of them because they love compacts.
Yeah, because I think they have the PA one too, don't they? Okay. Okay, well, seeing no other questions for that one, you can move on to the next one.
Great. All right. Chair Hansen and members of the committee, my name is Isabel Eliason. I'll spell that one more time just in case. Isabel Eliassen. And I'm again appearing on behalf of the Council of State Governments. Thank you for the opportunity to provide input on LR 233 and the Physician Assistant Licensure Compact. The Council of State Governments is a nonpartisan membership organization that serves 3 branches of state government. We also provide technical assistance for states on interstate compacts, including the PA Compact. The PA Compact is an interstate license compact or contract among states which allows physicians, PAs, licensed in a compact member state to practice in other compact states without the need for multiple licenses. Like other interstate licensure compacts, the PA Compact is designed to improve access to services, enhance mobility for practitioners, support relocating military spouses, improve continuity of care, and ensure cooperation among compact member states. The PA Compact reflects how states currently license PAs. For example, to participate in the compact, PAs must hold an unrestricted license, have no felony or misdemeanor convictions, have graduated from an accredited PA program, and hold current National Commission on Certification of Physician's Assistants certification. PAs who meet the uniform requirements are enabled to quickly obtain a compact privilege, which is equivalent to a PA license in another state. The PA Compact has no impact on a state's laws and regulations for PA practice and leaves state-specific licensure requirements in place. For example, any collaboration or supervision or controlled substance prescription authority requirements that Nebraska necessitates for practice would have to be met by a PA before they're able to exercise a privilege to practice. The compact creates a shared interstate licensure data system, allowing for near instant verification of licensure status. Through the data system, a privilege to practice or the authorization to practice in another compact member state can be obtained in a matter of minutes. The data system will also enhance public protection by ensuring that member states share investigative and disciplinary information with one another. We don't anticipate substantial additional costs for participating in this compact. Like with the dentist and dental hygienist compact, there may be a cost to connect your state's data system to the compact data system, and also the cost of the attendance of your state's commissioner at the Compact Commission annual meeting. The PA Compact is newly available for states in 2023 and is one of 15 interstate compacts available for states. Thank you for the opportunity to deliver this informational testimony, and CSG is available to assist with any questions regarding the PA Compact or other compacts.
Any questions on the PA? Okay, seeing none. That's all?
Yeah.
Okay, just making sure. Okay.
Thank you. Thank you very much for your time.
All right, thank you. All right, and next on the list, we got Caitlin Bilson with the Council of State Governments. Welcome.
Thank you. Yes, so Chair Henson and members of the committee, I would like to express my appreciation for your consideration of the Social Work Licensure Compact. My name is Caitlin Bison. That's Kaitlynbison. Also with the Council of State Governments. And I'm just going to provide some background educational information on the compact. So CSG, through its National Center for Interstate Compacts, we've facilitated the development process for all 15 of the active occupational licensing compacts, including the 9 that Nebraska is a member of. This includes ASLP, counseling, EMS, medicine, nursing, psychology, physical therapy, occupational therapy, and teaching. Nebraska is also a member of 38 other interstate compacts unrelated to professional licensing. There are approximately 500,000 licensed social workers in the U.S., and despite the high demand for social work services, licensees are currently limited to providing the services within their state borders, and the compact seeks to provide licensees with opportunities for multi-state practice, support relocating practitioners, and foster workforce development. Like the other 2 compacts Isabel just mentioned, the compact was created through a cooperative agreement with the Department of Sense and the Council of State Governments, and we've been working on this for the past 18 months, developing the compact language with stakeholders within the profession, from the Association of Social Work Boards, National Association of Social Workers, the Clinical Social Work Association, Social Work Regulatory Boards, the social work education community, and others. And this compact language was finalized in February 2023. The compact will enable social workers to obtain a multi-state license issued by their home state to practice in other states that join the compact, rather than get an individual license in every state in which they want to practice. Unlike the other 2 compacts that were just mentioned, they are compact privilege models. The social work compact is a multi-state model. So like the compact for a driver's license, each compact member state agrees to mutually recognize the licenses issued by every other member state. It's similar in form and function to the other 9 occupational licensing compacts that Nebraska is already a member of. A social worker must hold an active, unencumbered license in their home state to be eligible for a multi-state license. Licensees must also pass a background check and meet other eligibility requirements related to education and examinations. From a regulatory perspective, the compact preserves the authority of each compact member state to protect health and safety through the existing state regulatory structure. A licensee practicing under a multi-state license must abide by the laws and regulations and rules that govern the practice of social work in the state in which they were located. And the Nebraska Department of Health and Human Services has jurisdiction over anyone practicing in Nebraska under a multi-state license. The Social Work Licensure Compact also benefits military families, as Isabel mentioned, and like all other occupational licensing compacts, the Social Work Licensure Compact will be governed by a commission made up of member states. The delegate will be a representative from the social work section of the Nebraska Department of Health and Human Services. The compact will come into effect once it's enacted by 7 states. The compact is pretty new, so there's currently only 1 member state, Missouri. However, there are many states that are interested in introducing the bill in 2024. And in Nebraska, if it were enacted, Nebraska would have a seat at the table with the Compact Commission has its first meeting to establish the compact's rules and bylaws. Overall, the Social Work Compact will increase license portability for social work professionals in Nebraska, support military families, and improve access to social work services for Nebraska residents while maintaining the current system of state licensure. Additionally, by ensuring the sharing of investigative and disciplinary information among the participating states, it will allow participating state regulatory entities to better protect the public. And I understand that increasing access to mental health providers is a key issue facing states, and we believe the compact will help with that. Thank you.
Thank you. Are there any questions from the committee? One question I think I hear about these compacts, or that I've seen in some letters, is do these compacts have the ability to supersede state law?
No, so this would just be an alternative pathway that a social worker can take. We don't touch scope of practice or anything to do with the individual state license.
Okay, so I just wanted to reiterate that point. All right. And seeing no questions from the committee, thank you very much. Appreciate
Thank you.
it. All right, next up, we'll take Joyce Beck with the AARP.
Chair Hansen and members of the Health and Human Service Committee. My name is Joyce Beck, Joyce-Beck, and I'm here today as a volunteer on behalf of AARP Nebraska to provide comments on LR 233. According to the U.S. Census, more than 1/3 of Nebraska's population in 2021 was 50 and over. When asked, AARP members made it clear that one of the highest priorities as they get older is to be able to age in place. In fact, 90% want to remain in their homes as long as possible. In 2020, UNMC report 13 of the 93 counties have no active primary care physicians. The state has designated all counties except for Douglas and Lancaster County as a shortage area for at least one type of primary care specialty. 58 of the 93 counties are designated shortage areas for family physicians. As a nursing home and a hospital CEO for 28 years in Nebraska and in Colorado, I saw firsthand the PA's essential role in the healthcare delivery system. It often makes sense for PAs to take care of less complicated patients who need constant care and ongoing monitoring and let physicians concentrate on those with the most intense needs and complications. Access barriers often delay patient care, especially in rural communities and other underserved areas. Delays in care also contribute to delays in diagnosis and delays in treatment, which result in poor patient outcomes. In Montrose, Colorado, for example, we established that over 1,000 cardiac clinic appointments and follow-up appointments needed to be made in order to meet the needs of our patients. PA recruitment was paramount for that area. The PA addressed the clinic needs of many patients, freeing up the cardiologist for surgical interventions. While this example from my experience comes from Colorado, similar experiences can be found in Nebraska. Developing interstate compacts for healthcare professionals is essential to meet Nebraska's needs. In Fair County Health Services in Hebron, Nebraska, where I was the CEO, interstate compacts were particularly important to the triage nurses providing services to patients in Nebraska as well as Kansas. This drives home the point that facilities on border towns will find the compact advantageous. Enactment of the Physician Assistant's Licensure Compact will prove critical to enhancing and improving healthcare access in rural Nebraska and throughout the state. PAs are clinically versatile, they are cost effective, they extend the services of the physician practices, and they improve the care delivery to underserved areas. They are an essential part of healthcare workforce. Consumers in our state need better access to high quality primary and preventive care. And physicians' assistants have the training and the skills necessary to provide that care, especially for older people who need to receive that care in their own communities. Enactment of the Physician Assistants License Compact is an additional step forward to ensuring Nebraskans receive the care they deserve. So thank you, Senator Blood, for introducing this critical study resolution. And thank you to the committee for my opportunity to comment.
Thank you for your testimony. Are there any questions from the committee? Seeing none. Thank you very much.
Thank you.
And lastly, we have Bethany Berg as a PA to come testify.
Hello.
Welcome.
Chairman Hansen and members of the Health and Human Services Committee, my name is Bethany Berg, spelled Bethanyberg, and I'm appearing on behalf of the Nebraska Academy of PAs. I am a physician assistant working as the Advanced Practice Provider Lead at the University of Nebraska-Lincoln Student Health Center. Thank you for the opportunity to provide input on LR 233 and the Physician Assistant Licensure Compact. For nearly 50 years, NAPA has represented the interests of the more than 1,300 PAs practicing in Nebraska, including advocacy for quality, cost-effective, and accessible healthcare for Nebraskans throughout the state. It is our pleasure to provide this committee information on the PA Licensure Compact and its anticipated impacts to PAs, patients, and state administrators. NAPA did not request introduction of this interim study, nor has our board taken an official position on the compact, but our professional association wishes to be engaged as the legislature continues this compact. While we can anticipate benefits to the compact, we also want to ensure that we address concerns that our members have already raised related to issues ranging from telehealth to Nebraska-specific requirements like patient safety fee payments. Like many states, Nebraska is competing to recruit and retain qualified healthcare providers to meet the needs of patients. The role that PAs play in meeting these healthcare needs in Nebraska and across the country is critically important. 1/4 of PAs in Nebraska serve in rural areas, and approximately 30% of these PAs work in primary care. So it is important that the state look for ways to fully leverage the PA workforce to meet the needs of Nebraskans, and the PA compact can be a useful tool in this effort. If enacted, we hope this compact will strengthen access to medical services provided by PAs via the mutual recognition of a PA's qualifying license by other compact participating states. Nebraska is no stranger to interstate licensure compacts, having enacted 8 compacts for healthcare providers already. Like the other 8 compacts that the state already participates in, the PA compact is a constitutionally authorized, legally binding, and legislatively enacted compact among participating states. While NAPA is pleased to offer our insights into the benefits of the PA compact, we also recognize this is a nationwide effort. This year, 7 states filed legislation to enter the PA compact, and the new compact is receiving support, expertise, and counsel from respected organizations such as the Federation of State Medical Boards, the National Commission on the Certification of Physician Assistants, the Council of State Governments, and the American Academy of PAs. Should Nebraska join the PA compact, the compact would be administered from a compact commission and an interstate government agency comprised of delegates from compact member states. This would allow for the creation of licensure data system to improve information sharing between compact member states, including disciplinary information. States joining the compact would agree to recognize a valid, unencumbered license issued by another compact member state via a compact privilege. Licensed PAs utilizing the compact can obtain a privilege in each compact member state where they want to practice. Importantly, PAs using a compact privilege to practice in another state must adhere to laws and regulations of that state and are under the jurisdiction of the state's regulatory board in which they are practicing. The PA compact also adopts the prevailing standard for PA licensure and affirms that the practice and delivery of medical services by the PA occurs where the patient is located at the time of the patient encounter, and therefore requires the PA to be under the jurisdiction of the state licensing board where the patient is located. So by preserving the sovereignty of states' rules and regulations, the compact safeguards Nebraska's ability to regulate the profession, charge licensing fees, and preserve the structure of the state-based licensing system. If enacted, we anticipate that the compact will provide several benefits to PAs, patients, and state regulators. First, the compact will facilitate license portability, making it easier for PAs to practice without lengthy licensing delays or administrative burdens. Rather than obtaining an individual license in each state they want to participate, a PA can utilize the PA compact to apply for compact privileges through a streamlined process. This can make Nebraska more competitive in attracting high-quality practitioners. Licensure portability is essentially important for military families. The compact will more easily allow active duty military personnel and their spouse to obtain a compact privilege in Nebraska if they are licensed in another compact state. For patients, this could mean expanded care access to highly qualified practitioners and would also help the state facilitate practitioner mobility during public health emergencies. But beyond benefits to the patients, the state could benefit from improved cross-state collaboration, enhanced public safety data through sharing, and strengthened healthcare labor market. Nebraska's PAs stand ready to be a resource to you as you consider the PA compact, and NAPA thanks you for the opportunity to provide input on this important discussion. I'm happy to answer any questions.
Thank you. Are there any questions from the committee? Senator Beller.
Thank you, Mr. Chairman. Thank you for being here. How different are the license requirements from state to state? Or is this more just to cut red tape and kind of minimize delays?
I don't know that I could speak to the definitive differences between states. We can get that information, but I think depending on the state, it can vary quite a bit.
Okay. Because if I remember, so you have undergraduate PA school and then boards. That's a national standard, correct?
Correct.
Okay, so license. Okay, thank
Yep.
you. I
Yep.
appreciate it.
I got a question. You mentioned something about the patient safety fee. What is that?
I can get the details to be specific, but I know it's an additional fee that was recently added onto our license to help cover the Patient Safety Commission that is through the state of Nebraska, I believe, and I can get more detailed information.
I'd be curious about it.
Okay.
Okay.
We can follow up the committee and share that.
Yeah, that'd be great, actually. Any other questions? Just make sure. All right, seeing none. Thank you very much. All right, so that will conclude the invited testimony for LR 132, 232, and 233. And we'll invite Senator Blood back up here to close. And we did have some letters to the record while she's coming up here. LR 132 had one proponent, one opponent, and one neutral. A letter for the record. 232 had one proponent, one neutral. And LR 233 had two proponents and one neutral.
Can I ask who the opponent was?
Yes.
Because there's no
It
actual
was somebody
bill.
reporting themselves. And it was Melanie Steckelberg.
Okay, we're gonna have to give that person a
Lincoln.
call.
Yep, she has some good questions.
So I want to real briefly answer a couple of questions that were brought up that I think will be beneficial, that I can go ahead and help you out with right now. You had asked about the metrics in reference to the Pentagon. They actually maintain a website that is meant for military families where they share that data, and it's the Military One Source website. It's a very convoluted website, but the data is on there. No offense to the Pentagon. And then you were asked about how many of these compacts, how many states had joined these compacts. So I want you guys to be aware that actually these compacts are new. We had already gone through our 10-day process of dropping bills, and the window of time shut for us, but that's how new they were. They came out, a lot of these came out in like January, February. So we weren't able to participate when they were first dropped. But on the social work one, there's already been one state that's passed it and 6 states that are pending. And again, that's only in a 9-month period. The dentist compact, 3 states have passed it, 5 are pending. The PA compact, 2 states have passed it, 2 are pending, and 2 have introduced it. So like most compacts, I anticipate in the next 6 to 12 months, you'll see 8 to 10 states, and the year after that, more states and more states. And then I just want to, and they all touched down on this a little bit. We never change, so especially for Senator Ballard, we never change scope of practice ever. We remain sovereign when it comes to what's right and what's wrong. They can't come in and do whatever the heck they want. They have to abide by our rules. And the reason these compacts take so long to put together, they're not put together in a month, they're put together over years, is because they bring in the national organizations, they bring in local people, they bring in a lot of attorneys, probably really well-paid attorneys. And they make sure that the bar is set at a level that is acceptable for most states. There are going to be compacts that we aren't going to want to participate in. And one of those would be the APRN compact. That's one that I like to use for an example. If you read the body of that compact, you'll see where it says that it doesn't change scope of practice. And then 2 paragraphs later, it says it changes scope of practice. So we're very aware of what these compacts are meant to say, and we make sure that we don't change the language. In fact, Nebraska adds in additional language that pertains to protecting people legally that we get from the National Association of Nebraska Association of Trial Attorneys. And I think we're the only state that does that, but the compacts allow us to do that because it doesn't change the text of the compacts. So we add in extra protections in our state, and I'm really proud of that. And then you heard the story about the social worker who talked about how she couldn't provide care because the patient was in another state. I go back to the Psych Pact, and I think you were chair of the DHHS when we passed the Psych Pact. And I heard stories of patients would go on vacation and have mental health issues, and the Nebraska psychologists couldn't counsel them on the phone because that was illegal, because they weren't licensed in Florida or California or wherever the other person was vacationing. With these interstate compacts, they don't have to get 20 different licenses. They have to get their home state license. And then they get the ability, the privilege is what they call it, to practice in those other states, which if you think about it, is also financially beneficial sometimes because many of our psychiatrists can start secondary businesses by doing telemedicine in other states with these compacts. So again, people not leaving, but actually finding alternative sources for income. So with that, I'm going to close. So we all know that health is a vehicle. It's not a destination. What that means is that health is not a fixed point that you reach and then you hit the brakes. It's an ongoing journey, and we know it requires continuous care and often a lot of effort. Now, if we want to help Nebraskans maintain good habits and take good care of themselves so they can live fulfilling lives. We must make sure that tools such as better access to health care is available so they can strive to be the healthiest versions of themselves. Be they have broken bones, mental health issues, weight problems, long-term health concerns, whatever. Healthier Nebraskans mean that the residents of our state have better overall health. And to me, that is worth more than pretty much any law we will ever pass here in Nebraska. I made it fast.
I was gonna
Do
say,
you need more time to write your note?
no, that's
All
quick.
right.
Good. All right, just make sure any questions from any, yes, Senator Reapy.
Thank you, Mr. Chairman. Again, thank you, Senator Blood. I am a big fan of compacts. One of the questions that I had is, I have a note here that says it requires 7 states to create a compact.
It depends on the compact,
Okay.
but most states it's 7 to 10.
And that led me over to the comment that you had made about the psychologist who was in another state. And it talked about what if it was a state that was outside the 7?
Well,
And then it
you-
gets very awkward. It says, are there 7 in this compact and 10 in this one and 20 in that one? And how does how do you know for sure who's in what?
Well, first of
Other
all,
than
there's
Google.
there's maps, literally maps for every compact that shows you what state has it pending, what state has it passed, which is how we get our information when we're sitting on the side there. So we go to their compact websites. But also when you're in the industry, you know what states belong to your compact. And not everybody, here's the thing that we have to always point out. Well, you're just losing everybody over here. What I have to point out is that not everybody has to join the compact. It's optional. If I come to here to practice in Nebraska, it isn't that I have to join the interstate pact. It's a choice. And if I come from a state where there is another compact, I have that benefit of using my home state license and then coming to practice in Nebraska. So there doesn't seem to be, I can see you creating this confusion of maybe this is a problem, but we're not hearing that from anybody who participates.
Okay.
Because in your industry, you know who belongs to the compact.
Okay. I have one additional follow-up question,
Yes.
if I may, are we on the track for federal licensure?
Federal licensure, you mean universal licensure?
Yes.
It's my understanding that there is a senator in the body that is pushing that initiative. And that was one of the reasons.
At the federal level?
That's my understanding.
Okay.
But that's one of the reasons I wanted to talk about it today in the interim study, is that if we want to do things like that, the state or federal level, we just need to make sure that interstate compacts, be it state or federal level bills, are excluded from that. Because we can have more than one tool in the toolbox and we can all get along and sing kumbaya if we want, right?
Okay. Thank you, Mr. Chairman.
Yes. I may have one question. I should have asked this of CSG when they were up here. So when we do all these compacts, or what other states have done all these compacts, is there data that shows that there is the intention is being met?
Mhm.
Like, is there more is the safety, the quality of care, greater accessibility?
Yeah.
Like, that's the intentions of these compacts? Does that actually happen in the states that enact these compacts?
Yeah, to be really frank, if they weren't getting positive results, they wouldn't have done more compacts. The DOD didn't say, oh, I have this giant pot of money, let's do as many as we can.
Sure.
They started doing them, they saw success, and they tracked those metrics. And so it is the Military Families Office through the DOD that works on these compacts. You can talk to Daniel Logston at CSG or Matthew Schaefer, who is the Interstate Compact guru now. There's a lot of resources you can get this data, but let's be frank, they wouldn't have done more than one if they hadn't achieved success with that first one.
Sure. You're asking me to trust government now here. You know that.
No, I'm asking you to trust the industries that have participated in it.
Yep.
Yeah, I don't trust government either, and I'm a government official, so.
And it makes sense. I'm just curious, to what extent it does, and maybe some do better than others. I'm just kind of curious.
I mean, I didn't mean to minimize it, but again, let's be frank, they're not gonna put money, maybe they would, but the industries wouldn't keep coming on board and wanting to do this unless it had been successful in previous industries.
Sure, that makes sense. All right. Seeing no other questions.
Right.
Thank you very much.
Thank you. I hope you have an enjoyable afternoon with the rest of your hearings.
All right, thank you. All right, well, that will close the LR 132, and 232, and 233 for today. And next up, we have, let me get my notes here. Yep, I'm gonna make sure I get that. Should be John, right? All right, next up we have LR 190, and we will welcome up Senator Frederickson to open. Welcome to the HHS committee.
Welcome to the HHS committee. Should I go?
You can begin whenever you're ready.
All right. Good afternoon. Thank you, Chair Hansen and members of the Health and Human Services Committee. For the record, I am John Frederickson, JOHN-FREDRICKSON, and I represent District 20, which is in Central West Omaha. I'm happy to be here today to introduce LR 190, which is the first of two interim studies I'm going to be introducing today. LR 190 is a study examining how to better streamline communications on rules and regulation changes proposed by the Department of Health and Human Services relating specifically to Medicaid. So I've heard from numerous providers that processes in place by the department do not always provide adequate transparency to allow stakeholders to compare rules and regulations with changes that have been proposed. So I was asked to bring this interim study to look at ways in which processes can be improved. I did reach out to Director Bagley and invited him or someone else from DHHS to come and testify today. Unfortunately, they have informed my office that they will not be testifying at this hearing. I do understand from other discussions I've had with other DHHS officials that they are taking steps to try to improve this process. They did provide some materials to my office late yesterday, but unfortunately, we did not have an opportunity to discuss these materials with them. It looks as though they are scheduling a number of meetings, so I am encouraged by that. It is my hope that we can connect stakeholders directly impacted by these issues with DHHS officials sometime after this hearing and allow everyone an opportunity to discuss the process and make it a bit more transparent. I will let the testifiers we have lined up today to talk to you a little bit more about their own experiences. But in preparation for that, I did want to pass out a few examples of hearing notices, hearing comment sheets, and summaries sent after the hearings. This may be helpful to you as the testifiers discuss the issues they are having. The first document in your packet is an example of draft changes, as you will see marked in the upper left-hand corner of the document. The second document shows effective changes to the same regulations, as you will see in the upper left. The third is a hearing summary sheet for the same regulations. I'm also going to read an excerpt from a letter provided by the Nebraska Medical Association for this hearing, which I believe sums up some of the issues we're seeing. Quote, one of the areas where the NMA sees opportunity for the state to improve communications and transparency is during the rule drafting period. Often, the public may not be aware a regulation is being proposed, amended, or repealed until the agency publishes the draft rule and notice of hearing, which is required 30 days before the hearing. While the public hearing is an opportunity for the public to comment on a proposed regulation, it often feels as though this comment period is too late to meaningfully influence the rulemaking. The Nebraska Secretary of State's webpage on regulation process acknowledges that, quote, it is difficult to significantly change a regulation once it has been set up for a hearing, unquote. Providing enhanced notice of opportunity for comment during the rule drafting period would promote transparency and meaningful public participation in the development of rules and regulations, end quote. Stakeholders say that it would also be helpful for the agency to provide more narrative about proposed changes and rationale early in the process, and to provide information on changes that may be adopted after public input. Since these regulation and rule changes impact so many lives, I think we can all agree that they need to be handled in a way that allows the public to understand what is happening so they can weigh in and provide the best possible feedback to the department. I hope today's hearing will shed some light on this issue. And my hope is that DHHS will take the information we learned today into consideration as they strive to improve this process. With that, I'd be glad to take any questions you may have or ask those behind me to respond.
Thank you for that. Are there any questions from the committee? Yes, Senator Reapy.
Thank you, Chairman. Thank you, Senator, for being here. And I admire your motivation to take on the Medicaid delivery. It's never an easy task to go against the bureaucracy, if you will. So I'll be interested to learn more and to follow accordingly. I have great interest in Medicaid.
Thank you, Senator Rupee.
I guess that wasn't a question, was it?
I
We'll
appreciate
allow
your
it, I
comments.
guess. All right, any other questions from the committee? All right, seeing none, you're staying closed for this, I'm assuming?
Absolutely.
All right, good. Okay, so with that, we do have 3 invited testifiers. We will take the first one, Lori Sheriff for Boys Town. Welcome.
Hello, good afternoon. Chairperson Hansen and members of the Health and Human Services Committee, my name is Lori Scharf, LORISCHARFF, and I am here today on behalf of the Nebraska Association of Behavioral Health Organizations. We represent over 50 community mental health and addiction provider organizations, regional behavioral health authorities, hospitals, and consumer organizations. We would like to thank Senator Frederickson for introducing this resolution and the committee for getting it on the schedule. NABHO has a long history of dealing with overly burdensome and prescriptive regulations that do not improve patient safety or quality of care. Often these regulations conflict with the Joint Commission, which is the major accrediting body in healthcare. The process to make or revise existing regulations has not been collaborative and transparent. Rather than spending time recounting the problems of the current system, let us suggest a roadmap to a new process. Section 1. HHS identifies a need for new regulations or revised regulations. HHS contacts the affected providers at the beginning of the change process. We have numerous professional and other healthcare associations that would like to provide early input. Using the associations to gain early insight into how a change will affect patients and/or providers is critical. In many circumstances, these associations can help assess whether the change will have the desired effect and what unintended negative consequences may occur. Many of our NABHO providers are more than willing to provide this input. Section 2. Process needs to define exact language being changed from current regulations. We have proposed and have used a process in the past that demonstrates the exact language that is being changed. There's an attached model example to what I handed out. We recommend that HHS considers using this model to help facilitate transparency and communication. In this model, the columns outline the current regulation, proposed language, and/or request for clarification to include deletions, additions, and edits. This model also helps to define the reason and rationale behind the change. For instance, is it for clarification? Will it provide simplification? How will it affect safety and quality? Will it result in an unfunded mandate, or is the department going to increase the relevant provider rate to offset any additional cost? Will it be less prescriptive? Often the newer changed regulation is overly prescriptive and impedes innovation, effectiveness, and can drive up costs. If the rules and regulations are being changed for federal reasons, where are the specific federal requirements? Where can these requirements be found? The current analysis of the regulatory changes only focuses on the cost impact on state government agencies. This is a fundamental failure of the current process. This analysis example may be expanded to include financial impact on families or patients, financial impact on providers. Will this change affect access? Will the change affect the type of providers providing this service? Are there other operational impacts? Are there unintended consequences? How will the change be monitored and/or enforced? Impact on provider accreditation. The timeframe for reviewing the proposed regulations. We believe the hearings and comment periods are posted at least 30 days prior to the hearing, but please understand that there are impacted stakeholders who are not always aware of those notices. Posting information as to how to sign up for those comment periods would ensure all impacted stakeholders understand what they need to do to stay informed. The opportunity to communicate is critical for two-way communication on complex matters. We are requesting 30 days as a minimum for timely review. The need for HHS to consistently engage in active communication to provider and patients of new or changed regulations. Consistent, active communication to include communicating the proposed change and why the change is necessary and critical for success. Some providers are distrustful of HHS because they fail to communicate the what and why. There may be a simple explanations on some changes, but the why is not shared. When the department simplifies or delegates regulations, they need to take credit for their efforts, and we need to offer our thanks. Next steps. In summary, NABHO has had many years of experience with overly prescriptive regulations that have unintended consequences and have created unfunded mandates. We would suggest the following next steps. HHS leadership calls a meeting of the major stakeholders to discuss alternate processes. If there is agreement, then there should be a simple and short report back to this committee. If not, then we can work with members of this committee to create a revised process to fix the broken parts of the current processes. NABHO is very appreciative of the committee's time today, and we stand ready to help improve Nebraska's healthcare. Please let me know if you have any further questions. Thank you.
Thank you. Are there any questions from the committee? Yes, Senator Reapy.
Thank you, Chairman. My question will be is, and I think we had something I want to say, it was around the Scotts Bluff area where they wanted some flexibility in terms of how to use their resources because they had a particular case or something, and they were unable to do that. So my question is this, will this make us more nimble in meeting individual and agency needs?
I think that's the intention, just to eliminate that confusion, the burden, the intimidation that sometimes can occur when you see regulations that maybe don't make sense, being able to collect information from association and stakeholders to better understand how these regulations can impact the work that we do.
Okay, thank you. Thank you, Mr. Chairman.
Any other questions? Yes, Senator Walls.
Hi. Thank you. Thanks for coming. Can you talk a little bit more about the 30-day, the timeline or the time frame for reviewing the proposed regulation, the process? Because you mentioned 30 days and then you mentioned that you would like to see 30 days. So can you just kind of explain that?
Yes, thank you for asking for clarification on that. We've heard from some of our providers in our association that it seems at times that whether it's the providers not knowing, maybe timely notification of those postings. And so we feel that we're behind in being able to have thorough conversations with the organizations that we support, or that it's just being able to understand the access to when it has been maybe posted on the website or when those listservs come out. We just want to ensure that there's just clarity in, is there enough time if it's 30 days, if it's under 30 days, if there's a shorter time from that or a longer time from that, just really kind of clarity in that so that everybody has the ability to bring it back to their teams and have those really thorough conversations.
All right, thank you.
Any other questions? All right, seeing none, thank you very much. All right, we'll take our next testifier, Angie Lane with the Nebraska Hospital Association.
Good afternoon, Chairperson Hansen and members of the Health and Human Services Committee. My name is Angela Ling, ANGELA-LING, and I am the Senior Director of Hospital Preparedness and Regulatory Improvement for the Nebraska Hospital Association. The NHA thanks Senator Frederickson for introducing the interim study. and we appreciate the opportunity to provide testimony for LR 190 regarding streamlining communication on rules and regulation changes proposed by the Nebraska Department of Health and Human Services. Many of the rules and regulations apply to our hospital, and while we do our best to understand the changes, there are many ways we could improve communication and understanding during a regulatory change. There have been various process iterations over the years communicating new rules and regulations. A few years ago, DHHS changed regulations for just one chapter, reducing it from approximately 150 pages to 60 pages, with no list of changes provided. We had to go through each page line by line and determine what was changed, eliminated, or added. It was an extremely time-consuming task. Most recently, there was a review completed by DHHS, and a redline version of the document was published for review and comment. Much of the document had been moved to a different chapter, but the changes were not word for word. Also, in this specific review, there were many paragraphs redlined, but the new verbiage was stated a few pages later. Those documents are incredibly difficult to review and understand what is new, old with edits, and/or completely eliminated. Title 175, Chapter 9 of the Nebraska Administrative Code had a simple word change that would have made social work nearly impossible in rural areas by changing the old verbiage, quote, social work services provided are to be directed by a certified social worker, end quote, to the new verbiage of, quote, social work services provided are to be directed by a master's degree prepared social worker, end quote. While this may seem like a small change in terminology, it would have been detrimental change for rural Nebraska. There are multiple ways that we can improve these processes, and I appreciate that DHHS spends many hours working on these revisions. There are associations and stakeholders who would be more than willing to assist the department in these initial reviews to help provide upfront subject matter expertise. Allowing early collaboration will help the department preempt inadvertent complication of rules and regulations. Many large organizations use a matrix to help track the changes. I have included a copy with my printed comments on the second page. In short, it outlines the location of the information in the document, shows the old verbiage, recommended new verbiage, and the reason for the change. Allowing this information to be outlined in a standardized format with rationale attached will allow any reader reviewing the material to understand the changes and rationale leading to the change. The Nebraska Hospital Association would be happy to continue conversations on ways to work with DHHS to assist in simplifying rules and regs and utilizing the extensive network of expertise Nebraska possesses. Thank you for the opportunity to discuss this important issue today, and I will take any questions.
Thank you. Are there any questions from the committee? I might have one. So,
okay.
And this was maybe brought up in previous testimony. Is there a lot of concern with your ability to get notified of a change?
So
or more like the process after notification?
So when the notification comes out, you have to a lot of times be subscribed to the notification process, and that's how I get notified, or our advocacy team will get notified, and then the process starts. We have, for the Nebraska Hospital Association, we have a regulatory improvement advisory council that I help facilitate in its member hospitals. And once we get notified of those changes, we talk about it at our advisory council, and we try to have as many eyes on it as possible to do a review. But again, looking through different areas, bigger hospitals have their eyes on very different things, and rural hospitals a lot of times have their eyes on different subjects. So it is difficult. If you don't, even 30 days is very difficult to get through these large documents to understand what truly has changed. And if it was streamlined and understood a little bit better of where this rationale is coming from, was it actually changed, or did it just get delayed a little bit in the document and now it's just being restated? Those will help allow us to maybe meet that 30-day of review.
All right. Thank you.
Any other questions?
Seeing no other questions, thanks for coming. Appreciate
Wonderful. Thank you so much.
it. And there she is. Okay. And we have one more testifier, Sarah Marish with the Nebraska Appleseed.
Welcome back.
Thank you.
Chairperson Hansen and members of the Health and Human Services Committee, my name is Sarah Marish, Sarah Maresh, and I'm the Healthcare Access Program Director at Appleseed, testifying on behalf of Appleseed. We're a nonprofit legal advocacy organization, and one of our key priorities is ensuring that all Nebraskans have access to quality, affordable health care. And a key piece of that work is ensuring that Medicaid works well for the over 370,000 Nebraskans that rely on this program for their health care. I'm testifying on LR 190 today to discuss opportunities for our state to improve Medicaid state regulatory processes to increase accessibility and transparency. At Appleseed, we oftentimes have a little bit different of a perspective when we review regulations. We review them more from a law and policy perspective instead of a provider perspective, just for reference. And while there have been some positive changes made to the Medicaid regulatory process in recent years, we still see opportunities for improvements. Many folks before me have already testified to some of these. First, it can be difficult for people to know when those proposed regulatory changes are up for comment. People do have to subscribe to a specific website or websites to get information about those proposed regulatory changes. And those websites are difficult to find and are really only there if you know where to look. It would be helpful if the proposed regulations were posted in a more prominent place so everyone's easily able to see the regulatory changes that are being proposed when they're notified. Second, the current regulatory process doesn't provide a lot of information that's helpful about the actual changes being proposed. Typically, when regulations are proposed, the posting includes a general description of the regulatory changes and includes a document that actually shows the regulatory changes. And there are opportunities to improve both pieces of that process. First, these general descriptions don't provide much guidance as to what is actually being changed, and they're pretty vague. And so it would be helpful if the explanation at the beginning of those regulatory sections consistently listed the specific substantive changes that are being made. Additionally, it would also be helpful if the proposed regulatory changes that actually show the changes to the document are made more clearly and consistently. So currently, and I provided some examples just attached to my testimony, currently DHHS uses markups or red lines like others have referred to show the proposed regulatory changes, but these really have varied in quality. At times, DHHS will include a markup or red line that shows the exact changes that are being proposed by showing which words will be eliminated and which words are being added. And this is incredibly helpful and makes it really clear what changes are being made. However, DHHS doesn't always take this approach, and at other times, it doesn't show which specific changes are being made, but rather just completely strikes out a section that is being revised and notes that is being modified in another section. And that's something that other folks have spoken to before me, and that just makes it really difficult to understand what changes are being made and requires people to spend significant time going through and comparing where the changes are line by line to understand that. And if you take a look at the attachments that I included on the back of my testimony, the first page, if you flip to the front and back, shows what I would call the good version of the red line. And so you can see, especially on the back, it actually includes very specific strikeouts as to what's being modified and what is being added. So it's very clear. But the second example was also, and these both are just two examples that were taken in the last couple of months. So these aren't long time frames we're seeing here. But these section here on the second page attached to it, where it includes a large yellow highlight, shows kind of what I would call maybe the bad version of the red lines, where it doesn't really show the exact changes being made, just notes it's being modified. So we think one way to improve these processes is just to consistently use the red lines that show these exact changes that are being made so people can track those more easily. And finally, Medicaid has had a recent practice of adding an additional opportunity at times to comment on some proposed regulations through what they call an informal comment period, which we really appreciate. However, the time to submit those informal comments is usually really short, like about a week or so, and gives people little time to review and offer feedback. And so we suggest an informal comment period that's more clearly posted and also gives extended time for people to give that feedback and for DHHS to incorporate that. We know regulations are key to understanding Medicaid, and ensuring that the process is transparent and as accessible as possible is really important to make sure people are aware of their rights. So by prominently posting regulatory changes, improving the quality of descriptions, using the good red lines and extending and using informal comment periods more consistently, DHHS can really make great strides to improve accessibility and transparency in the process. Thank you, and I'm happy to answer any questions.
All right, thank you. Are there any questions? Senator Reapy.
Thank you, Chairman. You mentioned quite often about the red lines.
Yeah.
And my question would be has that been suggested but then inconsistently up? Because I don't think it's something that we can legislate that mandates that red lines must be there, but.
Yeah, that's a great question. So it's a little historical perspective. It's a little before when I started to enter into this world, but it's my understanding that in the past there was absolutely no red lines that were provided, or it maybe happened really inconsistently. And I think about 5 years ago, they started doing some of these like red lines where they were showing markups to some of the regulations. And so I think you can see here, and I'm guessing that was based off of stakeholder feedback, but I just wasn't around to confirm that. They just do vary quality right now. And so I think that's something where if it's consistently done, that would really improve the process if they use kind of the good format for that.
At your young age, have you ever known when they didn't red line or have that ability?
Have I known? I'm sorry, what was that?
At your young age, have you ever known a time when they couldn't red line?
When they couldn't,
Because
no.
the technology wasn't there.
No. And at the law firm I worked for before this, we had redline software that was very handy and easy to review changes for. That was really handy in reviewing contracts and things like that. So.
Now into the good days.
Yep, the handy software. I remember the names of it too. If DHHS wants suggestions.
Thank you, Mr. Chairman.
Any other questions, Senator Walls?
Thank you. You talked a little bit about the websites. How do people even know what website they're supposed to subscribe to? And then can you give an example of a more prominent place?
Yeah, that's a great question. So there are, if you like search the Secretary of State's website, you can subscribe to like regulatory changes there. And then there are like HHS landing, it's like a landing page that just talks about all of their proposed regulatory changes. And then if you want to subscribe to the informal Medicaid comment periods, you have to subscribe to a different web page to get notice of the informal Medicaid comment period that I talked about at the end here. And so I think people in the industry definitely know, the providers are really on top of it and know where to subscribe. But I think unless you know where to look, you probably won't stumble upon that. And I think there could be a lot of different places people can, more prominently have that posted. One example could be some of like the Medicaid landing pages or having, specific banners come up when there are key regulatory changes being made for folks. So I think there's a lot of different ways, and I'm sure a lot of other stakeholders would have some great ideas on that too.
Great, thank you.
Yeah, I think Angie alluded to this on the Secretary of State's page. There's a rules tracking system that they have in place and you can sign up for email alerts. So whenever they do change something, you just get an email alert. So it's on the Secretary of State's page.
Yep, exactly.
All right, seeing no other questions, thank you for coming. Appreciate it.
Thank you so much.
All right, well, we will welcome up Senator Frederickson to close if he wishes to.
Yes. All right, so I'll keep my close fairly brief. I want to just thank the testifiers, everyone who came here today on the time out of their schedules to testify and to educate us all on this. So my intention with this interim study was really to bring a little bit more awareness to some of the issues we're seeing in this area. And my hope is to pursue the least invasive way to improve this process. So, that's kind of the hope of the outcome, as I mentioned in my opening, is really that some of the stakeholders and DHHS can get together and come together and talk about ways that this could potentially be improved, and hopefully we'll see some progress there. So I'm happy to answer any additional questions folks might have.
Thank you. Are there any questions from the committee? Senator Reapy.
Sure, I have a quick question. Is it your intent to talk with the new incoming CEO of HHS prior to the next session?
I think that would be wise. I think it'd be good to meet together. Yeah.
I would applaud you for doing that. Thank you very much. Thank you, Mr. Chairman.
All right. Seeing no other questions, thank
All
you
right.
for your close. And so with that, we will end the hearing for LR 190, and then we will open the hearing for LR 202. And welcome back, Senator Frederickson, to open.
Thank you. I'm actually gonna get this over here real quick. All right. Good afternoon again. Thank you, Chair Hansen and members of the Health and Human Services Committee. For the record, I am John Fredrickson, JOHN-FREDRICKSON, and I represent District 20, which is located in central West Omaha. So I have to say, I am actually super, super excited to be here today to introduce LR 202. This has been a bit of a passion project for me this summer and during this interim period. And LR 202 is an interim study to examine the mental and behavioral health care needs of Nebraskans. So through this study, I seek to determine the severity of the shortage of mental health providers that we have in our state, as well as resources to evaluate potential best practices and increase access to mental health and behavioral health care statewide. So Mental Health America released a report earlier this year that ranks Nebraska 44th in mental health, meaning that we have a higher prevalence of mental illness coupled with lower access to care in our state. When looking at only youth, Nebraska ranked 49th in this study. According to recent data from the National Alliance of Mental Health, more than 257,000 adults in Nebraska have a mental health condition, and 1 in 6 U.S. youth aged 6 to 17 experience a mental health disorder each year. The crisis is real. The impacts of this crisis are everywhere. And the need, and for a number of reasons, people are not accessing the services that they need. Unsurprisingly, one of the issues hindering our ability to meet the mental health demand is workforce. Nebraska has made improvements in the number of providers, as testimony today from the Behavioral Health Education Center of Nebraska will show, but there are disturbing geographic trends coupled with an aging mental health workforce that we're seeing as well. We need to look at the implications of these numbers, identify what barriers are here, which barriers are in place to strong mental health workforce pipeline, and create and enhance the proper incentives and educational opportunities to meet the needs of all Nebraskans. One of the other major issues is how we build upon existing successes in our mental health infrastructure and create new touch points for access. Several providers will be here today to discuss some of these infrastructures. I'm particularly interested in what the data shows on the 988 suicide crisis line, which is a year in at this point, and how we can build upon that framework. And also the possibilities that are before us with the advent of certified community behavioral health clinics, which we passed into law earlier this year. Of course, much of what we must do is address the cost barrier. According to the National Alliance of Mental Illness, more than 40% of adults in Nebraska who did not receive needed mental health care did not do so because of cost. In addition to availability, access to cost, mental health stigma also continues to be a significant barrier. This is particularly true among vulnerable populations, including farmers and ranchers. Farmers and ranchers are nearly 2 times more likely to die by suicide in the U.S. compared to other populations, according to the Center for Disease Control and Prevention. There are also unique challenges related to other populations as well, including our long-term care community. Some of that will also be covered here today. I have also introduced a companion study to LR 202, which is LR 201. LR 201 is in the Judiciary Committee, and it is a study that looks specifically at mental health in our criminal justice system. While we will not be exploring this here today, the extent to which we can address some of the foundational issues with mental health will have enormous benefit for law enforcement, for our correctional institutions, and for the individuals that they serve. Our prisons should not be our largest mental health providers. As a mental health professional myself, I have seen many of these issues firsthand. The struggle is real, and we must do more. Never before has this been more important. And I think in Nebraska, we have been uniquely privileged to have a lot of private and public partnerships, specifically as it relates to behavioral health and mental health. And I've recently been meeting with some of the private philanthropists and have been blown away by some of what they've done. But I also think that this is a time that as a state, we also need to step up and meet that need as well. I will end this introduction by saying that we have a strong slate of stakeholders here today to testify. I hope today's hearing will help set the stage for the Nebraska Legislature to move forward on a strong mental health agenda next session. And with that, I'll be glad to take any questions you may have. Right in time, Senator Repeat.
All right, thank you. Are there any questions from the committee?
I could ask what I missed.
That's right. I'll ask one question though. You gave a statistic at the beginning of your opening that we're 44th in the country when it comes to mental health. I think I can't remember the exact statistic.
Yeah.
Was that before the introduction and the passing of Senator Wishard's LR 276, that Community Behavioral Health Center, that big bill we did last year?
Yes, the CCBHC bill.
Yeah,
So
that would kind of changed, I would think, where we're at statistically with other states. That was a big bill.
yeah, so NAPA will be here today to talk about where we are with CCBHCs and sort of how that is unfolding in the infrastructure. There's a lot of promise with that, to be frank with you. I'm thrilled that we passed that bill. I think that was one of our big successes as a legislature last year. And so, yeah, I think things like that are going to take some time to sort of go into place, go into effect to see impact. The statistic I cited was specifically kind of looking at the prevalence that we see of mental health conditions in our state, coupled with sort of access to care, right? So how I'm kind of taking that into consideration.
Cool. All right. Thank you. Senator Beller.
Thank you, Mr. Chairman. Thank you for being here, Senator. So in observing, we probably can all agree that mental health is an issue, and each organization has a different path forward. So from your experience and your research, have you seen collaboration between nonprofits, government, private sector, or is all decisions kind of made in a silo and then kind of distributed from that?
It's a good question. I mean, I think sort of whenever you're tackling any issue, I think obviously having collaboration across all interested stakeholders is extraordinarily important. I'll speak specifically to Omaha. I think one thing that we've been fortunate in Omaha is that we have had a lot of collaboration between the private industry and the public. We've seen a lot of private-public partnerships. An example of this is the new behavioral health hospital that's being built through Children's. That's been done a lot through private philanthropy, which is really kind of enabling that to exist. And so I think we can continue to see more collaboration. One thing that I've noticed is, and this is just kind of anecdotal, but in conversations I've had with folks, both, just constituents and neighbors and other parents in my kids' school to also just as stakeholders in the community, there's a universal agreement that we need to be doing more surrounding mental health.
Thank you.
Yeah.
All right. Seeing no other questions, we'll see you at the closing.
You'll see me at the close.
All right. So we will start the list of invited testifiers with Annette Dubois with the Nebraska Association of Behavioral Health Organizations.
Good afternoon. Good afternoon, Senator Hansen and members of the Health and Human Services Committee. My name is Annette Dubas, ANNETTEDUBAS, and I am the Executive Director for the Nebraska Association of Behavioral Health Organizations, otherwise known as NABHO. We represent 57 organizations, including community mental health and substance use disorder providers, the regional behavioral health authorities, hospitals, and consumers. We sincerely thank Senator Frederickson for introducing LR 202 and for your attention today. It really is important that we have this conversation and take this deep dive into what are the behavioral health needs of Nebraskans and determine what we need to do not only to support the existing system, but how do we ensure that it evolves to provide evidence-based care and treatment that is culturally inclusive. As with anything that you build, a strong foundation is critical. Without that, the potential is always there for the building or your system to crumble. For our association, our mantra is adequate rates ensure the ability to build capacity, which in turn assures there is access to care. So as with any business, if your revenues do not cover expenses, it's difficult to maintain services, let alone expand them. For those who provide health care, and especially behavioral health care, and rely on the public sector for compensation. These rates continue to be below the cost of providing services. I want to acknowledge that for the past several sessions, this legislature has made provider rates a priority, and we have seen steady increases each year. Without these increases, we would not have been able to weather the extreme challenges brought on by COVID and the higher than usual inflation rates. Please know that we are sincerely grateful for these rate increases, and they have made an impact on providing care and supporting workforce. Attached to my testimony is a summary of a 2021 survey that we did related to workforce challenges and a 2022 member survey where the questions were focused on how were the services supported by the rate increases and the impact of high inflation. Not scientific surveys, just information from membership. And the responses also did indicate an appreciation for the rate increases. So while there are many things that we can do to support a sustainable behavioral health system of care, it continues to be our goal to seek rates that provide that strong foundation. And it seems to me like the time is right to revisit the Division of Behavioral Health's rate study and consider developing a rate methodology that would support a sustainable, flexible funding mechanism for mental illness and substance use disorder services. Workforce is a challenge across all sectors, and behavioral health is no exception. The ongoing struggle pre-COVID has only been exacerbated. The National Council for Mental Wellbeing did a nationwide workforce research project in March of this last year, surveying 750 mental health and substance use disorder providers. This survey reflects what is happening in Nebraska as well. Nearly half of those surveyed say the shortage has caused them to consider other employment, even though they want to stay where they're at. 62% are experiencing moderate to severe burnout. And of those surveyed, 82% are concerned about adequate reimbursement rates. I'll be happy to send you the link to that survey that goes into more detail. Through their research, they did identify some specific solution-oriented steps that have a federal focus, but I think that they can also be adopted to state policy initiatives, including the CCBHCs that Senator Frederickson brought up. That model is already showing that those clinics are able to hire an average of 27 new positions per clinic due to their ability to pay higher wages because they're getting a rate that actually covers the cost of services provided. Another key initiative through their research is to look at state actions that reduce burdensome administrative requirements. A lot discussed in the previous LR. So much time is being spent by these providers on data reporting and different procedures for each managed care company, some duplicative, and it's taking away from patient care. Another area we can look at as well is our licensure process. Right now, there's a significant delay in getting provisional license applications through the process. We're hearing upwards of 3 months. And if these individuals aren't licensed, they aren't out in the communities providing care. So looking at that would be helpful as well. There is no single answer to how we ensure a strong and sustainable system of care for behavioral health. But if you look at the issues identified in this LR, workforce, integration, access to care, especially for underserved populations, adoption of best practices, and barriers in general, they all have some connection to how we pay for services. If rates do not cover costs, it's very difficult to look beyond just what's being done to maintain. Rates are the bread and butter of every behavioral health provider's ability to provide care. Rates speak to and support every purpose of this resolution. So while we're watching the impact of CCBHCs, I believe they are showing us that if you take a community approach to providing whole person care and then pay those providers for the actual cost of services, it's a win for everyone. Citizens who are mentally and physically healthy are better able to engage in their communities and schools in a positive manner. And we look forward to working with Senator Frederickson and this committee to find ways to continue support for mental health and substance use disorders in our state. Thank you.
All right, thank you. Any questions from the committee? Senator Reapy.
Thank you, Chairman. Thank you, Senator, for being with us. As a sideline observer, my sense is that particularly in mental health, and maybe more so in rural Nebraska, there are more, if you will, leaders than there are followers, that there are a lot of mama, papa, Rosie kinds of little operations, which then make it very difficult. I recall that when we first introduced managed care to Medicaid, we had hues and cries of people that couldn't get billed because prior to that, they would submit their bill, they got paid. Now they had to get prior approval. And just the magnitude of the onesie twosies, and maybe that's all there can be in smaller markets. I don't know. I'm an urban guy, obviously, and but with some rural roots, if you will. But how do we address, because my concern gets to be, is there so many providers, and as the old saying goes, everyone wants cooperation, but no one wants to be cooperated. So how do we streamline this without having a total government takeover? That I don't want either. I'm not sure that was a good question. I'm not even a question.
Well, it's not a question that has a simple answer. That's for sure. That is for sure. And if there was a simple answer, we would have probably had it already. But you are right about, especially in the more rural areas with our smaller providers, we mentioned the administrative burden, dealing with managed care companies. We're in Nebraska have 3 managed care companies who have 3 ways of doing things. And so if you're especially a small shop, you don't have a lot of extra staff. So you yourself are devoting the time to the authorizations and the appeals and the denials and all those other things. That adds cost to care, and it impedes access to care as well. So as an association, we are always in conversation with the Division of Medicaid and with the managed care companies, asking how do we help you help us, do a better job and streamline and speed up, payment. We're having some conversations now. We have providers who are looking at 60, 90, and even longer delays in getting paid. You can't pay your bills if your revenues aren't coming in. So these are ongoing conversations.
I think at some time we had suggested at least exploring a clearinghouse that maybe everyone would pay some hopefully nominal fee to get a concentrated group who does this on a daily basis, and they know how to deal with managed care A, B, and C with some determination to get collections.
Everything's worth a look.
I'm just an old recovering administrator. So.
Any other questions from the committee? I have one quick question, I guess I just thought of. It seems like a prevailing theme we have among healthcare organizations when they come to the state is increased provider rates. You call them loan repayment programs, some more of the financial aspect of what the state can do to help them out. You mentioned a little bit about administrative tasks, red tape, rules and regulations. I think it's something it seems like we don't address as much as what can we do to help you get rid of rules and regulations to make your job easier, more enjoyable. You can actually see more patients per hour, maybe, be more effective, I guess. And it seems like from a legislative perspective, that's where we get more bang for our buck, I guess, instead of just addressing Medicaid, the small section, or maybe not small in mental health, but when we can now affect the rules and regulations that affect all patients, I guess, from our perspective. Is there something in particular that you think is like one thing you wish the state would get rid of? A rule or regulation, you say, gosh, we only got rid of this one thing. It's a lot less paperwork we have to do, because I hear this a lot from hospitals and everything else. Is there anything?
There isn't anything that I'm aware of. I'm sure if, a provider that comes up, if you ask them that question, but there are so many rules and regulations that picking one particular one, but I think it goes back to the previous LR. If we can engage earlier in the process to really help Medicaid or whoever we're working with understand this is the impact of that regulation and make it be a workable regulation before it's implemented, because then we spend a lot of time trying to figure out how do we help you. We have to live with this regulation now, and it's costing us time and energy. So I think if we could figure out ways to engage sooner and be a more active part of the process, I think that could go a long way to saving money, streamlining processes, and making care the priority.
Awesome. Okay. Okay. Seeing no other questions, thank you for coming.
Thank you.
All right. Next on the list, we have Marley Doyle with the Behavioral Health Education Center of Nebraska.
Hello.
Welcome.
All right, good afternoon, Chair Hansen and members of the Health and Human Services Committee. For the record, my name is Dr. Marley Doyle, MarleyDoyle. I'm a psychiatrist and the director of the Behavioral Health Education Center of Nebraska, or Beacon, and am appearing today on behalf of the University of Nebraska system. Thank you to Senator Frederickson for inviting us to participate and bringing attention to this important issue. For background, Beacon is the state-funded behavioral health workforce development center that is housed at the University of Nebraska Medical Center. Our mission is to recruit, train, and retain the state's behavioral health workforce in order to improve access to behavioral health care for all Nebraskans. According to our 2023 preliminary workforce data analysis, the behavioral health workforce has increased by 44% since Beacon's inception in 2009. This is great, but it's not enough, and there is still much work to be done. In your handout, there's a bookmark here that has a QR code that will give you more information about the status of the behavioral health workforce. And you can even get information by county about the number of providers in each area of the state. But I'll just give you a couple highlights about pinch points that we're still feeling. So first of all, according to the Health Resources and Services Administration, Nebraska has only 48% of the behavioral health providers needed to adequately meet the need. And 88 of our 93 counties are considered mental health professional shortage areas. In addition, our workforce is aging. For example, in licensed alcohol and drug counselors, over 50% are over the age of 56. We also continue to see disparities between urban and rural areas, with urban areas outpacing rural in the supply of providers. This is especially true for psychiatrists and psychologists. So Beacon works with and is in close contact with behavioral health professionals across the state through many of our programs, but we've seen the need be exacerbated since the COVID-19 pandemic. And we've been in close contact through the dissemination of the Behavioral Health Workforce ARPA Awards. In 2022, Beacon received $25.5 million in ARPA funding to address workforce challenges related to the COVID-19 pandemic. With this funding, we instituted a competitive application and review process in order to disseminate the funds to all providers and organizations across the state. Since that time, we've awarded over 110 projects to behavioral health professionals and organizations, and 55 of those projects take place in rural areas. So we've learned a couple things through this process. So one example that we've heard is that providers that received awards are really surprised at the demand and the interest in their awards. So one of our award recipients is a rural community college, and they received funding to provide stipends to students receiving their alcohol and drug certification. They were shocked by the demand for these stipends, and many students would have been eligible for these awards had there been more funding available. And this is something that we've heard over and over again from the award recipients. They keep telling us that they could immediately use more funding to implement their projects, and they continue to be surprised at the demand for the projects, particularly in training and education. And we've seen this at Beacon as well. So when we announced the awards, we were inundated with applications. We received over 300 applications requesting nearly $75 million in funding for workforce projects. So obviously, there is a great need for continued workforce development funding and programming throughout our state. So while the pandemic has waned, the impact and effect on the behavioral health of Nebraskans and the behavioral health professional community still has quite the impact. At Beacon, we will continue to work to address the disparities that we see in order to improve access, but we know that we can't do it alone, and we appreciate your attention today, and I'm happy to take any questions you may have.
Thank you for your testimony. Are there any questions? Senator Reapy.
Thank you, Mr. Chairman. Thank you for being here. I have a question, and I'm looking at your handout here. Can you help me out with what is a prescribers and what is a non-prescribers? Is that pharmaceutical prescriptions, and is that all it is?
No, so this terminology is basically to kind of try to separate out the behavioral health professionals that are able to prescribe psychiatric medications and then the ones that do not and just primarily do therapy. So in the prescriber category are psychiatrists, psychiatric nurse practitioners, and psychiatric physician assistants. And then in non-prescribers, we have counselors, we have psychologists, marriage and family therapists, drug and alcohol counselors. And so that's kind of how we separate them. And then we try to look at distribution and try to figure out what we can do to make sure that we have enough of each provider in all areas of Nebraska. So but there, like I said, there are disparities, especially in the prescriber category in rural areas. It's quite a challenge.
Having been in health administration for more years than I will confess to, I'm troubled by the fact that a nurse practitioner, or in essence, a physician assistant, would have any prescription authority that wouldn't also be the authority of a psychologist, a qualified licensed psychologist within a scope of certain prescriptions. So, I don't see a nurse practitioner, and I love them dearly, would be over a psychologist, a well-trained psychologist. That's just an issue that I have. And I think that plays to the supply and demand in terms of patient access and how patients can be treated. So just more of a comment. You're welcome to respond.
Yeah, I mean, other states have looked into that as a workforce strategy as well. So
Less progressive states.
there's been a few. I mean, but yeah, I know that's definitely when you hear about people kind of putting out new ideas, that definitely is something that has been floated and other states have looked into. Yeah.
Okay, thank you. Thank you, Chairman.
Any other questions from the committee? I just have kind of a broad question, maybe a statistical question.
Okay.
Has the use of psychiatric medications for treatment gone up every year?
It's
Even pre-COVID?
It's really hard to study that because the demand for services has gone up since COVID. So we're seeing more alcohol use, we're seeing more depression, more anxiety. So there is a higher demand for services and then treatment. So it's hard to say whether that's because it's hard to know what came first. But I don't think there isn't anything that I know of that's unrelated to the demand. So I'm not aware of any data that says that prescribing rates have just gone up just for no reason. It's always tied to the demand.
Okay.
Yeah.
Just curious.
I don't know if I answered it.
Yeah. Thank you.
Yeah.
Seeing no other questions, thank you for coming to testify.
Thanks.
All right, we'll take our next testifier, and that will be Michelle Noonmaker with DHHS Division of Behavioral Health. I knew I was going to butcher that name. Welcome.
Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. My name is Michelle Noonemaker, spelled MICHELLENUNEMAKER, and I am the System of Care and 988 Nebraska Administrator for the Division of Behavioral Health at the Nebraska Department of Health and Human Services. I'm here today to provide you information on the 988 Suicide and Crisis Lifeline. In 2020, Congress designated the new 988 dialing code for the National Suicide Prevention Lifeline, with expansion to include access to a crisis line for any behavioral health issue. After a year of collaborative planning with stakeholders, including persons with lived experience, 988 Nebraska went live on July 16th, 2022. Nebraska has one call center in Omaha with services provided by the Boys Town National Hotline. Boys Town was the previous call center for the National Suicide Prevention Lifeline. Vibrant Emotional Health administers the national line, and 988 calls are first answered through Vibrant's automated recording. Calls are routed to call centers based on the caller's area code. The Federal Communications Commission has not approved the use of geolocation for 988 calls. If a caller lives in a state different than their area code, the call center still assesses the safety of the caller and then warm transfers the caller to an appropriate call center. So for example, if someone has a Nebraska area code of 402, 308, or 531, and they now live in Arizona and they call 988, they will be routed to the 988 Nebraska call center and will be assessed for safety. And then if appropriate, they will complete a warm transfer to the appropriate call center in Arizona. During the 2021 calendar year, the Suicide Prevention Lifeline in Nebraska received 8,777 calls. Call volume for 988 Nebraska was forecasted based on this data, and although there was an expectation of the call volume increasing, there was a significant increase with 988 Nebraska receiving 18,300 calls in its first year of operation. A 90% answer rate was set as the goal during the implementation planning, and the average answer rate was 95.53%. 988 Nebraska also answers texts and chats to 988, and the goal answer rate was 80% for chat and text, with a total digital chat and text answer rate of 88.3%. The top 3 reasons people identify for contacting 988 are suicidal ideation, anxiety, and ongoing support. Usually frequent callers use 988 as a coping mechanism. The top 3 age ranges using 988 are 18 years and younger, 30 to 39-year-olds, and 60 to 69-year-olds. These age groups align with the top 3 age groups at risk of dying by suicide. The majority of callers are in the Omaha and Lincoln geographical areas. Boys Town crisis counselors can triage, de-escalate, and make referrals for further services, and support doesn't stop after the phone call. In the first year, crisis counselors managed 96.3% of calls to Nebraska 988 without incidents. Of the remaining 3.7% of calls, crisis counselors contacted emergency services or mobile crisis response teams to check on a caller's safety. Mobile crisis response teams include licensed mental health professionals who provide in-person or telehealth risk assessment and assistance, and it is a voluntary service offered to callers who are in crisis. The Department of Health and Human Services Division of Behavioral Health contracts for mobile crisis response through regional agreements. In summary, implementation has been successful. It is too early to determine the overall impact of 988 Nebraska, but preliminary data and unsolicited feedback from callers indicate that 988 Nebraska is helping people struggling with suicidal ideations or resolving a behavioral health crisis. I have provided you a copy of the 988 Nebraska Fiscal Year 23 report. 988 Nebraska is providing a vital resource to Nebraska. Thank you for your support of 988 Nebraska and for the opportunity to be here today. I would be happy to answer any questions.
Are there any questions from the committee? Got a question, I guess. If you can answer, maybe you can or can't. You have on one of the pages here, monthly phone service levels. Is that usually indicative? I know we only do this for a year, right? I think so. I know it's hard to tell like yearly trends, because I've always heard that during the spring, for some reason, people typically tend to have more suicidal thoughts. I think it's because other people are getting out and they stay in their home. There's something weird about the spring. And it seems to follow the pattern that you have here with the amount of calls presented. Does that kind of follow the trend nationally, typically? You know?
I'm not 100% positive on that one. I'd have to check on that and get back to you.
Cool. Just kind of wondering.
Yeah.
I think it might be tax day.
That's true, yes. April is pretty high. All right. Any questions of the committee? Just make sure. All right, seeing none. Thanks again for coming. Appreciate it. All right. So with that, we will take our next testifier, Kyle Kinney from Boys Town. Welcome.
Good afternoon, Chairman Hansen and members of the Health and Human Services Committee. For the record, my name is Kyle Kinney. That's Kylekinney. I am the manager of the Nebraska Family Helpline and the 988 Nebraska Suicide and Crisis Lifeline at Boys Town, and a licensed mental health practitioner in the state of Nebraska. I'm here today to provide some information regarding the trends that Boys Town has seen and need for mental health support of Nebraska youth and families. First, Boys Town would like to thank Senator Frederickson for introducing LR 202 and for his commitment to the health and well-being of Nebraska's children and families. As I understand it, this resolution seeks to do three things: examine the mental and behavioral health care needs of Nebraskans, determine the severity of the shortage of mental and behavioral health care providers, services, and resources in Nebraska, and evaluate potential best practices to increase access to mental and behavioral health care. Boys Town provides an array of quality physical, mental, and behavioral health care services that meet each child and family where they are, so they get the right kind of care at the right time in the right way. The Boys Town National Hotline is a crisis call center receiving crisis calls, texts, and chats in order to de-escalate crisis, triage concerns, and link callers to appropriate community-based mental and behavioral health resources. Under the hotline, Boys Town supports the Nebraska Department of Education Safe to Help program, helps parents through the Nebraska Family Helpline, and provides suicide, mental and behavioral health, and substance abuse crisis prevention as a crisis center for the 988 Suicide and Crisis Lifeline. Even before the COVID-19 pandemic, our country was facing mental health challenges on multiple fronts. Across our country, people are stressed, and Nebraska is no different. According to the CDC, suicide is the second leading cause of death among adolescents. Our families, schools, and communities are impacted by this crisis every day as they work to help the many students and families experiencing mental health challenges. The following data snapshot illustrates the scope of the mental and behavioral health care challenges of Nebraskans. In 2022, the Boys Town National Hotline responded to 128,335 contacts. Safe to Help, Nebraska's K-12 anonymous reporting system, received 2,446 safety tip reports, with 35% of those reports being critical in nature. In the last fiscal year, the Nebraska Family Helpline received 5,332 calls for families seeking parenting support and resources to help their children experiencing mental health crisis. In its first year, the 988 Nebraska Suicide and Crisis Lifeline received over 23,000 calls, texts, and chat messages, with the top self-reported reasons people call them being suicide ideation, ongoing support for severe and persistent mental illness, and anxiety. Boys Town's intention in responding to these calls for help extends beyond de-escalation and triage. Our objective is to help individuals identify and connect with community resources to improve their long-term well-being and prevent future crisis. However, there are times when there are limited or no supports within communities to provide local services for those in need, or those situations where families experience the barrier of long wait times for higher acuity services regardless of where folks live. Expanding the available mental and behavioral health services for children and families is key to improved well-being and safe, healthy communities for all Nebraskans. Boys Town believes that when youth and families have what they need to address their mental and behavioral health needs, they are better able to enjoy the quality of life we have all grown to appreciate. We want to thank the state of Nebraska and the Department of Health and Human Services for the initiative and support in making the first year 988 crisis system one of the best in the country. In the same way as the state considers potential solutions to these issues discussed today, we urge policymakers to ensure that services are adequately and sustainably funded. Issues such as increasing the pool of qualified mental health providers, utilizing telehealth or other innovations to improve access for rural and underserved communities, and strengthening the array of interventions to include care for acute and long-term mental and behavioral health needs. Together, we can improve the way we address these needs for Nebraskans, but it's going to take some innovation and investment. Again, thank you for the opportunity to testify today and contribute to this important conversation. I welcome any questions you may have.
All right, thank you. Are there any questions from the committee? Senator Walls.
Thank you. Thanks for coming today, Kyle.
Absolutely.
On page 2, you said that there are times when there are limited or no supports within communities to provide services or situations where families experience a barrier of a wait time. Do you have data on the number of people who are experiencing those barriers?
I don't have the data. I'm sure there is someone out there compiling that. I can speak anecdotally. Prior to COVID, I could by and large get an outpatient counselor, a traditional therapist, pretty readily in your more populated areas. Out west, it would be a little bit more creative, but probably within a week or two by and large. Post-pandemic, that has stretched, right? There's a little bit longer waits. Still reasonable for an outpatient therapist, though. Reasonable. you start to look at those more higher acuity services, the wait time gets pretty extensive if there's even availability. Outside the hotline role, but in my personal practice, just recently had helped a client needing just a psychological evaluation. It was a 3-month wait, which was pretty standard. Everybody would expect this, right? Go to the initial evaluation. After 3 months, they're referred on to an additional functional assessment evaluation. That's 6 months out. So we're 9 months into the process of figuring out, hey, what should we do about this? And so you see that's a fairly common narrative. That availability for those higher end services is problematic.
And can I ask one more question? In the cases that are acute, what are the alternatives that you find?
So I can speak from what we would experience in the various hotline, Nebraska Helpline 988. We're talking day-to-day maintenance. We're talking those community support resources where how do we figure out today, and then how do we figure out tomorrow? That maintenance that one of the hotlines that 988 can provide, and frankly is appreciated. The callers are looking for that service relationship where you're part of my safety plan. But that's a daily maintenance. That's not a long-term solution for those folks. And so, what's the right solution? I think that's why probably we're all here. But when it isn't available, it's daily maintenance planning, which you help parents, you help families understand that. They don't love that though. So what are the alternatives?
Senator Ballard.
Thank you, Mr. Chairman. Thank you for being here, Mr. Kenny.
Absolutely.
Can you walk me through an individual calls 988 and then what happens?
Yeah, that's great. So the vast majority of callers that are calling 988 at this point, because again, we're 1 year in, probably we're utilizing the suicide prevention lifeline before as part of their managing their daily suicide ideation. These are folks that probably are suffering from long-term severe and persistent mental illness. And so it becomes part of that daily maintenance, that safety planning, that de-escalation, and then connecting to resources as appropriate. A lot of those callers, they're very, what we'd say is resourced up. They have a lot of the services in place. It's part of the plan. For those that don't have resources, we're going to work with them to connect with the right services, whether that is outpatient therapy, what's available. We have a resource database of over 1,600 Nebraska services that provide mental health, behavioral health care across the state. So we're prepared to connect them to the right services statewide. Partnerships with the different providers, the behavioral health authorities, your mobile crisis response providers, those kinds of things to get the right service in place as in a timely enough fashion. For those higher end calls, so those where they are escalated, they're in a behavioral crisis, we're not able to safety plan, we're not able to de-escalate, but there's not that imminent risk. At that point, we're going to attempt to connect them with a mobile crisis response provider who's going to connect with them largely at the direction of the caller, whether that's a face-to-face response, that's a phone response or a telehealth response, or even at a centralized community location. They're going to meet with them, whether that's a peer support specialist, a mental health therapist, different kind of professional roles as a team, and they're going to meet with them, they're going to de-escalate, and then they're going to connect them to a series of aftercare services that are individualized for that person that are available through that mobile crisis service. And then for the last kind of the most high, that's where we were experiencing imminent risk. They're imminent risk of harming self or others. And so at that point, we're going to use the emergency system, whether that's 911, local law enforcement, emergency medical services, where they've done something to enact in their life, those kinds of things. And that's right around 2.5–3% of all calls. The vast majority of calls resolve over the phone with a connection to local services, which is a good thing, I think.
Thank you.
Can I ask one more question? Thank you. So in the crisis situation, I guess this is the question I was trying to ask before. Do you, or how many times do you utilize law enforcement or detention centers as being the provider temporarily?
Yeah, it's so right around 2.5–3% of the calls result in an emergency services system response, whether that's just emergency medical or local law enforcement, or most likely it's going to be a combination of the two through your local 911 center who's going to navigate that with us.
Okay.
So that's, it's about 2.5–3%, give or kind of month by month. Going back to the seasonal question, there are definitely seasons where you see some of those more high acuity calls where there are higher rates of suicide. September and October, which we're right in the middle of, does tend to be our our busiest season of the year. Coming out the holidays, of course, and then spring certainly can be a high acuity.
Yeah, I think according to statistics, it's kind of a misnomer. Everyone always thinks that more people have suicidal ideology or tendencies around the holidays in the winter, but it's actually during the spring.
Yeah.
It's kind of weird thing. So.
Yeah. Exactly.
Any other questions from the committee? All right. Thank you for coming.
Thank you much.
All right. And our next invited testifier is Tammy Lewis Arendt from Centerpoint. Welcome.
Thank you. Good afternoon, members of the Health and Human Services Committee. My name is Tammy Lewis Arendt, TAMILEWIS-AHRENDT. I'm the Executive Vice President and Chief Operating Officer at Centerpoint. We're a Nebraska nonprofit celebrating 50 years of providing mental and physical care, substance use treatment and services, supported housing, crisis intervention, and street outreach with locations in Lincoln and Omaha. We're also a CCBHC. I'm here today to represent the provider voice. When the COVID pandemic swept through the nation in 2020, many industries shut down and went home to wait. Not community behavioral health providers. We kept our doors open, providing support and services to those struggling with new issues of isolation and loss of normalcy. We innovated on the fly, figured out new ways to respond to people, and held up healthcare workers, first responders, teachers, families, students, and more. Financially, we survived through the generous programs like the CARES Act and increased philanthropy. We made it work. Here we are 3 years later, and while the virus may be less worrisome, the aftermath of that global crisis is not. We continue to see increases in behavioral health symptoms across all age groups, increases in substance use, anxiety, depression, and suicide. Our work has only just begun. Unfortunately, our workforce is depleted, burned out by the extensive response to the pandemic, choosing retirement, moving into less intense and higher earning roles in private practice, or getting out of the field altogether. The nursing shortage got national, even global attention, but there's an even greater shortage in licensed clinical therapists. Job postings that used to have 2 to 3 applicants will now sit untouched for weeks and even months. And it's not just clinical positions, it's all of the roles impacting our entire system. Staff shortages mean we can't serve everyone waiting at the door. We can't respond to all the phone calls for help, or even open up new programs and spaces to meet the needs of the community. We will have to work together to address this shortage through innovative approaches to service, improving our licensing process, addressing barriers to reciprocity, and by thinking about new ways about who can help and how they can help. Licensure can take months to process an application. This is the starting point for a clinician, and no billable services can be provided without this. In a world where I can apply for a $100,000 loan in a few clicks on my phone, it's difficult to understand why an electronic application for licensure can take as long as 6 months. Let's investigate the process and figure out ways to streamline and standardize the work. Reciprocity is also a challenge. The behavioral health world has come to rely on telehealth providers to fill the workforce gaps. This typically means employing or contracting with someone from another state. If they're able to bill CMS, the Center for Medicaid and Medicare Services, in Missouri, Georgia, and South Dakota, it shouldn't take months of waiting after completing all the additional requirements to provide care in Nebraska. We need to dig into reciprocity requirements and evaluate a more streamlined method for provider validation. One other consideration that impacts licensure and may improve the workforce shortage is to license master-level social workers separately from other clinical professionals. This is a common practice in other states and fits within the federal payment model for Medicare. It's a complicated system to explain, but ultimately means that we lose social workers who are skilled therapists to other systems and states where their degree and scope is recognized. There's hope on the horizon for some of us in the form of CCBHCs. These integrated health clinics provide a bundled payment mechanism that ensures coverage for services that are currently reimbursed. In addition, providers are exploring new ways to partner and collaborate to increase capacity and serve those waiting for help. We've developed partnerships with law enforcement and school districts, collaborated with primary care providers, critical access hospitals, and other types of organizations to improve access and quality of care. Rate increases help, but we need to look at systems that ensure regular adjustments to rates, something stable and secure. We also ask that you consider reinstating the $10.3 million in the DBH funding to the regions and give them the flexibility they need to better support providers and the community behavioral health network. And finally, we want to be part of the solution. We're skilled at innovating under pressure, being creative in response to needs, and most of all, doing a lot with a little. Thank you for your time today.
Thank you. Are there any questions from the committee? Senator Walls.
Thank you. I'm asking a lot of questions. I'm sorry. First of all, I have a couple questions. Do you know what the waiting list looks like for people who are waiting to get their licensure processed? And then why? Do we know what the holdup is?
You know, I wish I could answer that, Senator Walls, but I've sent 3 emails in the last month and have gotten 0 responses from the licensure division. So I don't know what the holdup is. We have an individual who we've literally been waiting 6 months for them to get their license. It says in process on the website, and we can't get a response from anybody in that department. So I wish I could tell you.
All right. Well, thank you.
Mhm.
Any other questions? Seeing none. Thank you for coming.
Thank you.
All right, so with that, we'll take our next testifier, Patrick Kreifels with Region 5. Welcome.
Thank you. Good afternoon, Chair Hansen and members of the Health and Human Services Committee. It is my pleasure to be with you today and talk about the behavioral health needs across Nebraska. My name is Patrick Kreifels, Patrick Kreifels, and I am the administrator for Region 5 Systems. I'm here today on behalf of the Nebraska Association of Regional Administrators and the Region 5 Systems Governing Board. Thank you to Senator Frederickson for bringing LR 202 forward and continuing to advance the conversation around these important topics. The regional behavioral health authorities play an important role in the recovery-oriented system of care provided across Nebraska. Each region encompasses a set of counties across the state. For example, Region 5 is comprised of 16 counties in southeast Nebraska. Behavioral health needs vary across the state, and decisions are best made at the local level. The region's infrastructure provides specialized coordination functions that are unique and not available from any other entity or organization. These efforts include problem solving, working across various systems to develop partnerships, providing education to the community, advocating for improvements and changes as needed, and understanding the inner working details of the system to contribute to its success. Providing a true recovery-oriented system of care continues as our primary focus to include promotion, prevention, treatment, and recovery supports. There are fundamental differences between Medicaid, probation, and the Division of Behavioral Health regions, and all systems are needed to create a complementary payer system in Nebraska. Medicaid is a state-federal partnership to provide health services to low-income families, seniors, and individuals with disabilities. Reimbursements to providers are made after services are delivered based upon set fee schedules and covered mental health and substance use services defined by a state plan, which is approved by the federal government. Nebraska probation focuses on rehabilitation and accountability to improve community safety and provide services to adults and juveniles to become productive citizens. As discussed above and previously, the regions focus on a recovery-oriented system of care. The behavioral health system continues to experience workforce shortages with the provider network, with significant turnover rates of employees ranging from 10 to 44% within one region. Providers did receive a behavioral health workforce stabilization grant from the regions across the state to help preserve and recruit a skilled workforce so they may meet the ever-emerging behavioral health demands. Every 30 hours, a Nebraskan dies by suicide, and it remains the second leading cause of death among 10 to 24-year-olds. The Office of Inspector General of Nebraska issued a report stating 27% of youth involved in the child welfare system are at imminent risk for suicide, having current suicidal thoughts, plans for suicide preparations, and means. Regional behavioral health authorities are expanding their crisis continuums to include somewhere to call, the 988, including crisis lines with providers, someone to respond, mobile crisis response across the regions, and somewhere to go, youth family crisis response centers and adult voluntary crisis stabilization centers. We have an aspirational goal of reaching 0 deaths by suicide, and efforts are focusing on implementing the zero suicide framework within provider networks and throughout the community behavioral health continuum. We are expanding evidence-based practices with dialectical behavioral therapy, motivational interviewing, and cognitive behavioral therapy safety aid to aid with the increasing competence and confidence of the workforce while supporting youth and adults with creating a life worth living and moving forward in their recovery. Other initiatives across the regions include youth systems of care, local disaster response, mental health, residential treatment, peer support, and a planning coordination to disperse the opioid remediation settlement funds to help abate opioid use. We continue to monitor the Medicaid unwind and ensure the region's funding is available to provide for the public safety net of vulnerable adults with severe persistent mental health conditions and substance use, and youth with serious emotional disturbances. Continued flexibility in our budgets and reimbursement methods that will help us address the varied and local needs across the rural, frontier, and urban communities are desired. We are pleased that the Division of Behavioral Health has begun exploring different methodologies to achieve this, and we appreciate their partnership. Lastly, de-emphasis on the most vulnerable populations in our community has natural consequences and outcomes. Jails are experiencing an increase in people who are presenting with SPMI and substance use conditions who need treatment, and the confined environment they find themselves is not conducive for them or the people managing these settings. People are waiting on average in jail over 100 days for inpatient competency evaluation and restoration. Additionally, access to the regional centers continues to decrease, and recently the regions are being asked to further reduce our bed allocation from 100 to 40 beds for people who have a mental health board commitment. The rippling effect this has on the system is confounding, and the hospital's experiencing times of being at capacity, as well as the crisis centers. And therefore that results in people having to be transported over 100 miles away for care. Historically, there was more collaboration to ensure there was flow and throughput with the regional center, and so that people didn't languish. With the decrease of access to 60 inpatient beds and no funding dispersed to the regions to bring up community integration services, this equates to a significant impact on the system. Thank you for allowing me to discuss these issues, and I would be happy to answer any questions. I look forward to the further conversation.
All right. Thank you for your testimony. Are there any questions from the committee? Senator Reapy.
Thank you, Chairman. I'm trying to define my own organizational structure. Now, within your region, do all of the activities of mental health, are they coordinated with you? Or what is the overall authority or control, if I may use that word, of mental health delivery within your region? Because it's my understanding years ago when the 6 regions were set up, they cover the entire state.
Yes.
And it's like each one is to coordinate then mental health delivery in that region, but I'm not sure that's the way it works.
That is the intent, and that is our focus and charge. And we have many coordination areas. So we coordinate prevention efforts and promotion efforts. We coordinate the emergency system for behavioral health, work with law enforcement officers to educate them on how to respond to if they encounter an individual or a person that has behavioral health needs. We do much training across the state in regards to that. There are additional rental assistance housing coordination. We create a network, so that complementary payer system, Senator, that I talked about, where Medicaid primarily pays for on a fee for service, and a lot of people are on Medicaid. It's that other catchment area, that public safety net. So individuals who are not on Medicaid, then we, and they're financially eligible, we will pay for those individuals.
You've used the word we coordinate a lot, so not to try to be too disrespectful, but it sounds like the regions, all 6 of them are toothless. Are toothless in terms of someone that goes off and does their own thing is irrelevant. There's no penalty for it.
Senator, could you tell me more about that in regards?
I'm saying if you don't have some overriding authority within the mental health services provided within your region, then you've got a lot of people that are out there just doing what they feel is free market to them. So my original thought was these 6 regions were to be fundamentally in charge, and to be in charge, you have to be in charge of the reimbursement.
We do receive an allocation from the Division of Behavioral
Yeah, but
Health.
do you pay anybody or deny payment?
Yes, we do have contracts with the provider network. So there are approximately 13 providers in the Region 5 Systems network that provide an array of services, from an acute hospitalization all the way down to an outpatient level of service for mental health and substance use. And those providers are accountable to that contract, and we work with them on that utilization and shifting funds throughout the year. Last year, we did talk a little bit about the restrictions that the Division of Behavioral Health were putting on us in regards to not allowing us to do shifts. That has been removed, and we're able to do more monthly or real-time shifts to meet the demands and needs of the providers and the people that they're serving.
Okay, fair enough. Thank you, Mr. Chairman.
Senator Day.
Thank you, Chairman Hansen, and thank you for being here today, Mr. Kreifels. Your testimony is very sobering, I think, for many of us here on the committee. A previous testifier, Ms. Arendt, had mentioned potentially looking at reinstating the $10.3 million in Division of Behavioral Health funding to the regions. Do you by chance, and maybe I should have asked her this question, do you by chance know what happened to that $10.3 million? Where did it go? When was it cut? How was that removed?
I don't know if I can answer all the question.
Okay.
I'll do my best to answer some of the question, hopefully, Senator. Last year, the regions worked to try to inform senators in regards to that 10.3 million, because it was initially included in our budgets as a result of a rate increase, a 15% rate increase. That was included in our budget for 1 year. And if you think about a time for a system to be able to respond to additional funds coming in, we need time to be able to plan and coordinate and contract with providers to get the funds out into the system. And so we had 1 year of that 10.3 in our system. And because of that did not continue and carry on in the budget, we lost an additional $346,000 just in my region in county match funds for people in behavioral health. Where the funds went, I am not exactly sure.
So it was essentially just cut from the budget.
Yes.
Okay.
I appreciate you asking that
Yeah,
question.
no, that's helpful to know.
And when we talk a little bit about, the decrease of access of acute beds in the state hospital by 60, and no additional funds are coming out into the community to offset that and to bring up services to serve those people that are on mental health board commitments, it's going to be a very sobering year.
Yeah. Thank you.
Thank you for asking.
Any other questions from the committee? Seeing none, thanks for coming.
Thank you for your time. I do appreciate it.
All right, we'll take the next invited testimony on our list, and that'll be Kirsten Reed with Leading Age Nebraska.
We're gonna have to look.
Welcome.
Hi, good afternoon. Chair Hansen, Senator Frederickson, the committee members, thank you so much for having me here today. My name is Kirsten Reed, KIERSTINREED, and I serve as the president and CEO for Leading Age Nebraska. We're a membership organization supporting long-term care providers, and we represent 76 long-term care providers across the state that provide a variety of services, including housing, home and community-based services, assisted living, and skilled nursing. I'm here to talk to you today about the needs of older adults with mental and behavioral health care needs. Nationally, Medicare enrollment is growing by 10,000 beneficiaries per day, and it is projected to continue to rise over the next 30 years. Additionally, we're seeing an explosion of chronic medical diseases that account for 99% of the Medicare spend nationally. From 2000 to 2020, we saw a 43% growth rate in the population over 80. And it is projected that between 2020 and 2040, the growth rate for that same group is going to be 113%. So in Nebraska, we are on track to match that same growth rate in our population. Our current population over the age of 65 is 16.9%, and it's expected to increase to 22% by 2050. While the growth of the younger population is beginning to decline, that's going to lead to less support for those that are aging. This, combined with chronic illness, that is going to lead to a population that is aging that is going to require care in long-term care facilities. So just like chronic health conditions, the rate of mental illness and behavioral health in older adults is expected to continue to rise over the next several decades. The World Health Organization states that 20% of adults that are age 60 and over suffer from mental or neurological disorders. And currently, 6.3% of adults that are over the age of 65 report that their mental health was not good 14 or more out of the past 30 days. The percentage of those with severe mental illness in this age group is also continuing to rise. The Nebraska long-term care system of nursing homes has 198 skilled nursing facilities that provide care for those that need some kind of ongoing medical support. Of those facilities, only 17 of them are designated as being able to support someone with behavioral health needs. 4 of those are actually within our state correctional system, lowering that number available to the public down to only 13 facilities across the state. Assisted living and other community-based providers support do not provide a designation regarding behavioral health supports in Nebraska. There are very few options for older adults in terms of geriatric psychiatric professionals to address any ongoing mental health concerns. And this results in older adults being unable to find placement in suitable long-term care programs. The Medicaid reimbursement system for long-term care fails to meet the basic needs of care, and there is absolutely no differential for providing support to someone with complications from mental health or behavioral health in our long-term care settings. There's also a considerable risk for our nursing facilities to be able to provide services to those with behavioral health conditions. These facilities are obligated to provide for the safety and security of all individuals receiving services. And that means that they have to protect them against others that may intimidate, threaten, or physically injure them due to a behavioral health crisis. There are very few facilities in Nebraska that have a safe place and the advanced training for staff to be able to provide these services. Overall, our healthcare system is not prepared to support these folks with significant mental health or behavioral health concerns. In closing, I'd like to point out the report that was handed to you. That was a report that was completed by DHHS on our 3 state-operated adult facilities. A study that was completed in November of 2021 in investigating how to redesign these state-operated facilities to address the changing needs of those with complex medical and behavioral needs. I've provided you each copy of this study, and I'd be happy to point out a couple highlights if we have additional time. Thank you again for having me today. On behalf of Leading Age Nebraska, I appreciate the efforts on this issue.
Thank you. Are there any questions from the committee? Senator Day.
Thank you, Chairman Hanson. Thank you for being here today. I would love to hear the highlights from the study if you would be willing to share.
Absolutely. I was hoping someone would ask that question. So this was a report that was contracted by DHHS with Myers and Stauffer, and it was to develop a plan for the Beatrice State Developmental Center and the 2 psychiatric hospitals, so we have Lincoln Regional Center and Norfolk Regional Center. The premise of the report was to identify opportunities that will further advance the focus and supports provided by these facilities into the future and be able to respond to the current needs in Nebraska. And the report breaks down 3 key areas. So first is the development of an older adult older adult system of care. Then the second one is a forensic system level of care. And then the third one is a sex offender system level of care. So for our population, we're really looking at that system for older adults. There are many folks that are at these community or these facilities that are aging. And so on page 9 and 10 of the report, it talks about assessing, there's 4-step plan for this. So the first one is assessing the needs of the population, and then the structural capacity and licensing requirements that would be needed, redesign and development of the program to meet the needs, and then developing administrative and operational facility resources to support those needs. Step 3 of that process describes the growing needs of the older adult population, particularly those who are aging, but also have significant behavioral and mental health conditions. One of the things that I think is really important to me is that as we're looking at that, you know, these facilities used to be the safety net when we had a nursing home or other community places that weren't able to fill the need for that person due to their situation. And there's really nowhere to go. So once someone enters a nursing home and they determine that they can't handle their behavioral health needs, there's nowhere for them to go because they can't go to one of those institutions. And once they've been admitted to the nursing home, it's the nursing home's responsibility to continue to provide care. So it goes on to talk about, you know, that piece that there's really nowhere to refer those patients to. And then that's also compounded with the limited amount of community-based services that are critical in this hurdle to kind of handle the entire population. Page 12 of that also talks about the care for older adults, which it points out that the needs of the community have changed, and DHHS, as I said, used to fill that role as being an alternative setting when things are not feasible, such as safety, cost effectiveness, or willingness of providers. And as such, that we need to have a comprehensive long-term care plan for addressing the needs of older adults with complex conditions and considering placement and treatment of aging Nebraskans with co-occurring medical conditions, behavioral or severe and persistent mental illness in an ongoing state system for the future. I could go on.
Thank you. I really appreciate that.
Any other questions from the committee? Senator Reapy.
Thank you, Chairman. Is there some confusion between dementia and mental health in terms of you're this or you're that?
Great question. I'm not a medical provider, but I would say that there's, in the long-term care area, I don't think there's as much confusion, but I think there is among the general public. So there is a difference, and what we're seeing in folks that are being admitted into nursing facilities, they understand what dementia is, and they know that they're going to have complications and behavioral issues that may come from dementia. But what we're seeing now is more and more of the population entering a nursing facility due to medical issues that actually has what I would call severe and persistent mental illness. So there's a difference, but you know, just because you're aging does not mean that mental health conditions go away. So as people are growing older, we're seeing more and more of that in our long-term care system.
Mm-hmm. Okay.
Yeah.
Thank you. Thank you. Thank you, Chairman.
Seeing no other questions, thank you for coming.
Thank you.
We'll take our final testifier, and that'll be Sharon Saff with Assistant Inspector General for Child Welfare. Welcome.
No, it's been a long afternoon, so I will go as quickly as I can. Good afternoon, Chairperson Hansen and members of the Health and Human Services Committee. For the record, my name is Sharon Saff, SHARENSAF. I serve as an Assistant Inspector General of Nebraska Child Welfare under Inspector General Jennifer Carter. I'm here today to provide testimony on her behalf as Inspector General Carter regretfully is unable to attend. The Office of Inspector General for Nebraska Child Welfare, or the OIG, was created in 2012 by the Nebraska Legislature to provide accountability for and oversight of Nebraska's child welfare and juvenile justice systems through independent investigation, identification, and monitoring of systemic issues and recommendations for systemic improvement. I appreciate the opportunity to speak before you today regarding the pressing issue of mental and behavioral health care needs among Nebraskans. The OIG acknowledges the importance of addressing this issue, particularly in the context of suicide prevention within Nebraska. While these topics are related, they are distinct, with suicide prevention serving as a crucial component of mental and behavioral health care. It is important to recognize that mental illness on its own does not directly lead to death by suicide. However, it is a significant risk factor that can elevate the likelihood of individuals experiencing suicidal thoughts or attempting suicide. My testimony today has a particular focus on suicide prevention, especially for youth involved in Nebraska's child welfare system. In June of 2023, the OIG issued a report of investigation into the suicides of 3 system-involved youth titled Death by Suicide, a 3-case review. A copy of that report has been included with my written testimony. The report offers recommendations aimed at addressing the issue of suicide among youth in the child welfare system. These findings articulated that the OIG did not consider the agencies or the employees working with them responsible for the deaths. The review also identified that the Department of Health and Human Services, or DHHS, and their partners across the state are committed to reducing instances of suicide in Nebraska. However, the report highlights the need for suicide awareness and an impactful response within DHHS, particularly with regard to youth in the child welfare system. One undeniable reality is that adolescents as a group are already at an increased risk of death by suicide. When we shift our focus to youth involved in the child welfare system, we find an even higher level of vulnerability. These youth report higher rates of suicidal ideation and self-harming behavior. It is concerning to note that a youth made a ward of the state and placed in foster care is 3 times more likely to attempt suicide than a peer who is also involved in the child welfare system, but not in foster care. I want to emphasize that the heightened risk does not imply that all adolescents in the child welfare system will experience suicidal thoughts or behaviors, but it does underscore the critical need for an awareness and an impactful response. The National Strategy for Suicide Prevention advocates an approach that includes identifying a vulnerable population and then building capacity within the system that serves them. In this context, child welfare staff, foster care providers, and case managers play a pivotal role as they are uniquely positioned to identify youth at risk of suicide and connect them to life-affirming resources and effective treatment services. With this in mind, the OIG recommended that DHS and their Division of Children and Family Services, or CFS, develop a comprehensive suicide prevention plan to be implemented through policy and procedure, and that the division actively participates in the Suicide Prevention Coalition. In addition, the OIG made the following 3 recommendations. The OIG recommended that DHHS mandate the completion of gatekeeper training for all CFS case managers before they have independent contact with youth and families. Gatekeeper training has been proven effective in increasing knowledge, developing a positive attitude towards suicide prevention, and enhancing confidence in the ability for someone to intervene with an individual at risk. Gatekeeper training has been successfully integrated across schools, healthcare settings, juvenile justice settings, and law enforcement settings, along with faith-based settings. Nebraska law already requires that all public school employees who interact with students receive annual suicide awareness and prevention training. Furthermore, yearly booster training for all case managers should be required to ensure ongoing competence. This training should not be limited to case managers, but should be extended to all newly hired division staff within their first year of employment. This training should be standardized and incorporate evidence-based practices.
Sharon, could you just narrow it down a little bit? You're out of time.
Oh,
But
sorry.
I want to make sure.
I was reading.
Yep. I just want to make sure you finish your thoughts
Okay,
though, at least.
yep.
So maybe just narrow it down. a
The
little bit.
OIG also recommended that they establish very similar recommendations as far as training and implementation for child placing agencies within the foster care system, and just as importantly, enhancing those suicide prevention efforts with foster care parents, both licensed and unlicensed. With the unlicensed foster care providers, we recommended that they find a way to provide that at no cost, whereas licensed providers can do it through their pre-service licensure. And I think the last thing I will close with that's extremely important is that DHS did accept all of our recommendations with a commitment to implementing them by 2025. And with that, the OIG would like to express gratitude to Senator Frederickson for bringing this legislative resolution. And I thank you for your time today.
Thank you. Are there any questions from the committee? Senator Walls.
Thank you. I just want to make sure I understand. So currently there's no suicide plan in place in the CFS system. Is that what you're saying? Like there's no training available for foster care parents right now?
So as the report articulated, CFS, independent of all of the other parts of DHS, does many things that would fall under suicide prevention, but they are siloed. So what we recommended is that they take all of these things that they're doing and put it together in a single organized plan that then has very specific policy and procedure to go with it. So they have lots of elements that speak to suicide prevention. They don't have an organized plan. And they lack maybe some overarching coordination with resources such as regions, Division of Behavioral Health.
Okay. And then you said that DHS would not be implementing this or coming up with their plan until 2025.
So in their response to our report, they, along with accepting all of our recommendations, which was the overall plan, policy and procedure to back that up, and then those 3 separate recommendations, which is including this kind of training for caseworkers, foster parents, and integrating it into child placing agency contracts, that in doing that, they would have that in place and integrated with a rollout date of December 2025.
Okay, thank you.
Any other questions? Senator Reapy.
Thank you, Chairman. My question is this: did the investigation explore gender dysphoria and associated risk with suicide?
No, Senator Reapy, it did not. No, it was based on 3 critical incidents reported to our office. So our scope was limited only to those 3 suicides, and none of those deaths by suicide incorporated the issues that you questioned.
Okay. I just thought, given the issues of last session, it might have. Thank you. Thank you, Chairman.
Any other questions? Seeing none. Thank you very much. All right. So with that, that will conclude the invited testimony for LR 202, and we'll invite Senator Frederickson back up to close.
All right. Thank you, Chair Hansen and members of the Health and Human Services Committee. I really appreciate you all taking the time, especially during the interim, to be here to engage with the testifiers, to ask questions, and to, I think, facilitate a space where all this could come out and we could speak about all this. I also want to thank all of the testifiers who took time out of their day and their schedules to be here today. I think it was incredibly important to hear from everyone. This is something that my office has been working really hard on this interim, as you could see from the testimony we heard. I think sometimes when so here's what I'll say. I think sometimes when we think about mental health and we hear a lot about mental health, it can kind of feel sort of grim. And this is a crisis. I'm not trying to be Pollyannish or sugarcoat this at all. I will also say that I do want to highlight some of the successes we heard about today. And, for example, DHHS has accepted all the recommendations from the OIG's report. Whenever there's a death by suicide, that's tragic. And I think that it's fortunate that we had the report that investigated those 3 deaths. And the fact that DHHS is willing to sort of take on those suggestions, I think is really, really encouraging. Other things that I think are really, our folks from Boys Town testified a little bit about the 988 hotline. They were being very humble. We have done really well in Nebraska with the 988 rollout, especially when you compare our rollout to other states. So that's something that as a state we can be really proud of. And part of that has to do with the infrastructure we had in place with the family helpline, for example. We were able to plug and play pretty quickly with that. So 988 on a federal level is a tall ask, but we've done really, really well in Nebraska. And I think that's something that we should be really, really proud of. The other thing I'm going to say is that, what's clear is that we have a real diverse set of stakeholders who are really interested in mental health. And I think that we are at a time right now as a society, I think nationwide, but I think certainly in our state as well, we're seeing a broad spectrum of support for behavioral health and mental health initiatives. And I think that this is something that we as a legislature can really come together on and hopefully move the needle on a little bit. Again, there was a lot that was highlighted today that was really important. There are 3 things I want to really kind of point out. One is the licensure backlog that we heard about a little bit. I mean, that is really concerning, and I think something that we need to look into. Again, I'm a proponent of the least restrictive or the least prescriptive kind of paperwork. Senator Wall says paperworky, but I'm a proponent of, if we can solve these things without putting it into statute, great. If it's something that would benefit from legislation, excellent. I think we should pursue that as well. But, you talk about workforce, the lack of providers, folks who are waiting 6 months for licensure, those are folks who are ready to go, who are ready to see patients. And so that's something that we need to be really kind of considering. Another thing that was really fascinating for me in this study was that I learned that I believe, and I don't want to misspeak, but I believe we had 19 educational programs in our state that train behavioral health providers. And that's the whole spectrum, anything and everything from psychiatrists to drug and alcohol counselors, like the whole spectrum of folks who provide behavioral health services. And one thought that I had was, well, how do we get more potential students interested in this as a career path? But what I've also learned is that we have interest in this profession. We have interest in this field. And I think the testimony we heard from Beacon today highlights that when they were giving out grants, those dollars are sucked up quickly for these opportunities and for these positions. So part of the issue is, the question becomes not so much how do we ensure that people are interested in this field, but how do we ensure that there are spaces in educational programs or seats in these programs for people to be trained, because there is an interest in the industry and in the field. There's no question about that. The final thing I'll highlight before I open it up to questions is, so part of, like I said earlier, with the Boys Town testimony, we've done really well with 988. So around, I think folks maybe have heard that around 2.5 to 3% of the 988 calls require the involvement of law enforcement. And I think that's a really nice relationship to have between 988 and law enforcement, to be able to have that immediate response. I do think it's worth noting that the way we currently have it is that with 911, we don't have that reciprocal relationship with 988. So if someone calls 911 simply out of familiarity with 911, for example, but it might be a more appropriate call for 988, we don't currently have that transfer going the other way as well. And so my other interim study I mentioned earlier, LR2R1, which is in judiciary, takes a look a little bit at that as well. So just wanted to highlight that for the community, the committee in additionally. So with that, I will wrap up. Again, thank you all for the time, and thank you to Chair Hansen for facilitating this, and I will be happy to answer any questions people have.
Are there any questions from the committee? A whole bunch of them. None? All right. Well, thank you for bringing this, and thank you for coming and bring all the testifiers. So with that, that will conclude the hearing for LR 202, and that will include our hearings for today.
Thank you.
Jen was wondering about that.
Are you going to be here tonight?